Hello, good afternoon.
Good afternoon.
Yes, good afternoon.
Do you hear us?
Yes, I do.
Okay.
Just a question from here, from Cameroon. We had a difficulty yesterday to connect because of our internet connection. I don't know how we can catch up with the first day of the symposium.
Hi, dear friends from Cameroon. You'll have a recording of what happened on the first day of the symposium. And if you have any questions that you would like the different speakers to respond to, I would be happy to put you through with those speakers.
Oh, yes, I would like it.
Yeah.
Thank you very much.
Shall we give another 5 minutes or so to let people join?
Hi, Gary.
Hi, good morning or good afternoon.
Good afternoon from here.
I hope you're all keeping warm. It's 15 degrees below zero here in Toronto this morning.
It's 30 degrees here.
Centigrade, 15 degrees.
Sorry about that plane crash.
Yeah, oh my God! Thankfully, no one was seriously injured, but
That's a miracle.
yeah, it's amazing. It's amazing that the plane crashed and was upside down, and everybody survived. And they said some people were injured, but no life-threatening injuries. So
fantastic. That was great.
Yeah, very fortunate. But I think it got something to do with the weather here, which has been terrible.
I think it's the weather. Weather was terrible from what I saw.
Somebody probably needs to mute their microphone. Or Jaden, can you mute that? Thank you. Jaden has the master controls. People are starting to trickle in, I can say.
Gonna need video is disabled.
Maybe just another couple of minutes, maybe.
First, going down. Doors closing. Please mind the doors.
Everyone has to remember to mute their microphone unless you're wanting to speak. Perhaps, Eve, perhaps we should start so that we
I
don't
think we
get too
should,
far
yes.
behind. So maybe on behalf of Eve and myself, just to welcome everybody back. We had, I think, a very interesting and stimulating day yesterday. We talked about psychological care. We talked about symptom control. We talked about the quality of dying and death from a clinical point of view, from a research point of view. And I think there's lots of engagement from all of you. And I think we are going to have an equally interesting day today. I don't know, Eve, if you would like to say a few words of welcome as well.
Yes, a warm welcome to you all, dear friends. I'm so delighted to see all of you online. The team from Masaka, the team from Cameroon, Mary, Leah, Liz, the team from Sudan. Very, very welcome, and thank you for accepting to spend the afternoon with us. So we have a very exciting menu for the day. We are going to have some presentations on grief and bereavement in Africa. This is a very important issue with lots of mental health implications. And I'm glad that we are now raising awareness around it and confronting the stigma and rallying social support to all the people who need it and creating safe spaces for them to grieve in a healthy manner. And then we are also going to talk about aging and mild mobility. Many of us might be crossing over to floor 5 or floor 4, and this is where all these issues of aging, mild mobility, and then most importantly, dementia. We have distinguished presenters this afternoon, and these include our own Professor Segane Musisi. Dementia is a big issue. The level of awareness is so low. Patients and families are struggling, and communities don't understand what is going on. So here we have an opportunity to learn more about the bolts and nuts so that we can support our patients. We are also going to talk about issues of end of life and advanced care planning. How can we support and empower patients and their families to tell us their wishes early enough so that we don't have to run to courts of law, to call in police, or do things that are against their wishes. And we will conclude with an interactive session that will cover research on end-of-life care, death and dying, including dementia and other advanced diseases. And this afternoon, we are also so delighted to have Dr. Muchibi, who is the Executive Director of Uganda Alzheimer's Association. These are conditions that are commonly linked to witchcraft because people don't understand what is going on. Therefore, we look forward to a lovely interaction. I'll hand over to the moderator of the day, Dr. Kennedy Nkoma, who is a research fellow from King's College, London. Dr. Kennedy Nkoma, over to you, please.
Thank you so much, Eve. Thank you so much, Gary. Just to confirm, can you hear me?
Yes, we can.
Okay, thank you so much. Yeah.
Yes, we can hear you.
Yeah, Eve and Gary have really given us a brief overview about what is going to be discussed today. So maybe without really taking much of your time, I will go straight to introduce the first speaker, who is the going to start the presentation this afternoon. So this is none other than Professor Segane Musisi, who is the former head of psychiatry at the Makerere College of Health Sciences His main area of research interest is dementia research in Uganda, and he has is also interested in terms of looking at the challenges that patients with dementia experience in Uganda, as well as the training needs and palliative care needs for patients with dementia in Africa. So Professor Musisi has trained in psychiatry at the University of Toronto and has extensive experience in psychogeriatrics, mental health in Africa, as well as integration of psychiatry into general medical practice. And he has published widely in dementia and all other chronic illnesses. We're talking of HIV, mental illness, and the like. So over to you, Professor Musisi. Thank you.
Thank you, Dr. Kennedy Nkoma. I'm very pleased to be talking to you today. I'm more so because my teacher is right here among us, Professor Gary Rodin, who introduced me to liaison psychiatry at the University of Toronto. Gary, maybe you may want to know that some of my students are also attending, so those will be your grandchildren. So we are going to talk about first an overview of dementia in Africa, and we are going to take the Ugandan experience. Next slide, please. So the question is, what is this dementia? Dementia is a chronic disease process marked by progressive cognitive, or to put it more simply, memory impairment in clear consciousness. It's a complex process involving an interplay between specific pathways in the brain and leading to loss of synaptic connections and disruption of functional networks, which translates into memory impairment and other disturbances, as we shall see. DSM-5 classifies as two really subtypes: major neurocognitive disorder, you can call it dementia for easy talk, and mild neurocognitive disorder, but we'll not go into a lot of that. Next slide, please. So why talk about dementia in Africa? Dementia, as we said, is a progressive illness leading to death, so it's terminal. But the rate at which it progresses depends on the type of dementia. Opportunities for prevention of secondary dementias, there are primary dementias and secondary dementias, meaning reversible dementias, are many in Africa, and we always miss this opportunity. But the other dementias, the primary types, are also very many here. Now, family members, care partners, and people living with dementia often have contradicting goals and beliefs for end-of-life care. Do we just prolong life for the sake of prolonging life, or do we improve quality of life, even if that life was shorter? These are debates that go on every day in Africa. But the estimated length of stay after usually diagnosis of dementia is between 2 to 12 years or 3 to 15 years, which means it can take a long time. But the biggest problem is end-stage dementia, which we shall see. Dementia has stages 1, 2, 3, 4. But the third and fourth is where most of the problems are. Older populations and dementia are increasing in Africa, and this therefore makes the problem of dementia right at our doorstep. However, long time ago, extended family systems cared for the old, the ill, but now these are disappearing, leaving dementia care unattended to. Next slide, please. Now, if you see that slide, there are about 55 million people living with dementia worldwide. And this curve is almost now vertical going up. As you see there, the red, the females are a lot more than the males. About 60% of people living with dementia actually live in low and middle income countries, including Africa, and certainly so in Uganda. And every year, about 10 million people get dementia worldwide. By 2050, about more than 130 million people will have dementia. Prevalence of dementia increases with age. So as the population in Africa also begins to age, there will be more cases of dementia. Next slide, please. Next slide. What are the types of dementias that we tend to see in Uganda, in Africa? And I thought I should divide them into two. I'll begin with what is most commonly talked about, the so-called reversible dementias or secondary dementias, which are due to infections like HIV/AIDS, meningitis, encephalitis, or due to intoxications like alcohol or drugs, or due to trauma, accidents, traumatic injuries, war injuries, and vitamin deficiencies like B12 and other things. But the dementia in older populations, people above 60 years old, is also here with us with increasing age, mainly due to brain degenerations, Alzheimer's disease, vascular dementias, frontotemporal dementias, or mixed types. But also the old infections are also there, like syphilis and intoxications like alcohol, and of course the degenerations, malignancy. But also the other not so commonly talked about dementias also exist, like Parkinsonian dementia, Lewy body dementia, Huntington's dementia, prion disease. Next slide, please. So, what is the biggest problem caused by dementia? One would think it's deteriorating in health, but there are many people who are ill in Africa, and for that matter, in the whole world over. But the biggest question which comes is loss of autonomy. In other words, an individual who looks physically well, is pleasant, is affectionate, and has lived long enough, is successful, is a patriarch or matriarch, then begins to develop inabilities to make decisions or makes wrong decisions. In other words, mental competency becomes challenged. And this becomes a very big problem, especially in cultures where patriarchy and age are revered and are considered very authoritative and dignified. So the four components which are usually impaired as, does this person understand what they're doing anymore? Yet they're physically okay, they look okay. Can they communicate a reasonable choice? Do they appreciate what they're doing? Can they reason well as they used to? These things begin to become questioned, and therefore complicating decision-making. And this becomes a problem, whereby now you have to bring in outsiders into the family, like professionals, to begin to make decisions. And this usually causes problems in family. So family members and carers who often have seen changes in the individual don't know what to do, partly because of that, number one, that these are people who have lived long enough, were revered, were authoritative, they were the patriarchs. So this decision-making is complicated for family members, and then they have to call in these professionals. Next slide, please. Next slide. So part of that problem about decision-making is that they begin not being able to look after themselves. They can't know when to dress, they can't know when to take a shower, they can't know how to shop, they can't look after themselves. So I wanted to know who takes now over this in Africa. So we did a study in 2015 looking at people who had dementia. There were about 53. And we wanted to know who are the carers before we could go ahead and begin to take solutions or begin to provide answers. And we found that most of the carers of people with dementia are actually families, and they're usually women, especially daughters, who looked more about the demented elderly mothers or grandmothers, sometimes sons also, or spouses. But when you look at that table, the spouses were more so for males, not females. And these were younger spouses. So it meant that these older people, males, tended to marry again, second wives, third wives, and stuff like that. But the women who were demented and older hardly had any care. They had to rely on their children, hence the daughters. Some were just left to look after themselves. A few grandchildren did, but there were hardly any in institutions, except for nuns in usually Catholic missions. Next slide, please. So look at that competence. Look at that gentleman. He looks very dignified. He's elderly. He looks very physically healthy. He's pleasant. He's smiling, but he cannot make any decisions anymore. and the family doesn't know. You can see that a person like that in a home has looked after all the people who are supposed to be looking after him, who revere him. But now he can't make decisions anymore. And they're going to make decisions which he may be opposed to. That's where the problem begins to come. Next slide, please. Then it comes this other problem where you find an elderly couple. In Africa, many generations used to live together. But now children are moving out to towns for lack of jobs or for finding jobs, or they're going abroad, leaving their elderly parents behind. And sooner or later, one of them develops dementia, like that lady there. And her husband, who is elderly, looks on at his wife, very disturbed. The lady is overwhelmed by what's going on. And then you begin to get in opportunities. You begin to get in undue influence. Conmen, fraudsters, land grabbers beginning to come in at the expense of the elderly. Next slide, please. And then comes in this thing. So they can now not make their decisions. Who is going to look after their estate? Can they make wills? And by the time this question comes up, it's already a little bit late. That's why you heard in the beginning Eve talking about advanced care planning, which is almost always absent in most of our situations in Africa. So there are no lasting powers of attorney whereby people could make decisions about who is going to leave legal documents, who is going to manage their estates, for example, who is going to care for them in terms of managing their banks, collecting their pensions if they have any, paying bills, collecting benefits, or selling their land or their home. And as I said, there are no advanced care plans and no advanced directives. So at that time, the family goes into a panic and they don't know what to do. And these people cannot anymore make decisions or make wills. Next, please. And yet everybody recognizes that they're getting older. So what are these psychiatric issues or psychosocial issues that concern us? They are what you find in advanced dementia. You have, for example, problems with pain. Patients cannot complain about their pain because they can't communicate it very well. Sometimes it becomes confused with other issues. They become incontinent, infections, they develop pressure sores. This pain, as we said, is very common, especially in end-stage dementia, and sometimes related to various issues, including falls. And yet, when other healthcare providers come in, they give them minimal dosages of, say, painkillers, which does not help them very well, for fear of making them confused. And also sometimes they may be sedating, and the families usually complain, thinking that you're hastening the death, of the individual. We have talked about infections, and people have to be on antibiotics, and other issues. Then comes in these psychiatric drugs, because patients develop so-called behavior and psychological symptoms of dementia, hallucinations, agitation, sleeplessness, wandering, aggression. These drugs of memory don't necessarily improve those conditions, but yet people fear psychiatric drugs. They say these are drugs for, quote, mad people. But you're giving their former Professor Musisi now, you're saying that he should be taking these drugs. Families begin to protest because of a misunderstanding of these things. And then at the same time, when they're agitated, when they're wondering, when they're aggressive, people fear, and you should also try not to use physical restraints. How do you manage them? These are the issues that come in. So you always find that they need family members.
Looks like we have lost Professor Musisi.
Can we message him to let him know that he's frozen?
Yeah, if are you able to message him, please?
Yeah.
If you can-
Probably we could have the next presenter, Kennedy, as Professor returns.
Maybe we suggest also that Sigani log off and then log on back on. We can ask him to.
Okay, would you like to? I hope you will let him know. Okay, then let me introduce the next speaker, who is Dr. Janet Nikagedu. This is going to be a recorded presentation, isn't it, Janet? Yeah. But briefly.
Hello.
Yeah, hello.
Yes. Sorry for jumping in, Kennedy. I just gave Seganai a call, and he said he was trying to connect back right now.
Yes,
Okay.
I can see that it says he's joining.
Okay. So fine. Then thanks for that. Then let's just give him a few minutes to complete his presentation. Thank you.
Okay.
Maybe we should move ahead if she's going to
Yeah,
do that.
it actually looks like he's gone again. So maybe we should move ahead until he's able. Oh, he just entered the waiting room. Just 1 second. Let's see if he's back now.
Okay.
Well, there we are. Okay, we can see you now again.
Thank you. So we were here, but this brings in the question now of palliative care in dementia. Palliative care is an approach that improves the quality of life of patients and their families when facing problems associated with life-ending illnesses, of which dementia is one, through prevention and treatment and relief of pain, suffering, and misery. Misery is what I put on because that's what you get in terminal dementia. We identify problems early, assess, and treat. The goal of palliative care in dementia is to improve quality of life of the patient and the family. Family is important. It calls for comfort care, understanding, supportive care, and symptom management. Next slide, please. So the question is that where do you care for these people? In their homes, in hospices, in nursing homes, or by frequent hospital visits? But we also another problem, which was in pandemics. How do you care for these people? How do you support the family? Next slide, please. Next slide. And how do you care for them? Guidelines we give: avoid heroics. Educate the family this is a terminal illness. Avoid lies. Don't tell them it's witchcraft or demons or whatever it is. You tell them the truth and what has happened to the individual. But you use controlled disclosures. Don't call in the family in one meeting one day and you tell them everything. Slow by slow disclosures. And you may talk about advanced directives, which many families don't want to hear about. Discuss medications. Support the family. Spiritual care. Traditional and complementary alternative care, which we talked a little bit about yesterday, because there's no cure for dementia. And of course, bereavement care, which Eve talked about, grief and bereavement. The question of euthanasia is very difficult to handle in Africa, and we don't usually want to talk about it. Next slide, please. So, what is primary palliative care in dementia? It is important because it gives high quality care for patients with advanced dementia. Knowing that dementia is a terminal illness, but in end-stage dementia is usually when you come in, because in early dementias, people are usually able to run around and do their own things. It means good communication, disclosing, sharing the diagnosis, counseling the patient through progressive illness, how the illness progresses, and really counseling the family and giving the family support, and referral where necessary. Families are supported by navigating any risks of problems like falls, fractures, these behavior and psychological symptoms of dementia, and how they fail to manage the activities of daily living. The guy is incontinent not because they choose to, but because they don't understand anymore about going to the toilet. Feeding problems, sleeplessness, wandering, agitation. These, you have to take a palliative approach when you're managing the patient. And monitoring patients' decision-making, not allowing them to make any more important decisions because their mental capacity is down, but at the same time, respecting their autonomy. This usually becomes a problem for relatives and friends, and always being aware that there are conmen around the corner. Then we discuss about medications. What is the role of medications in these people? Fully knowing that there's no cure, so far at this moment in time. And of course, monitoring their pain, and any behavior disturbances, respecting the diminished competences, knowing who is going now to make the decisions, and assisting with the activities of daily living, especially those distressing symptoms. Let's go to the next slide, please. So, what have we been doing for dementia research in Uganda? One is that we don't have good assessment tools that are culturally sensitive, appropriate, and easy to use, especially by non-specialists. You'll hear about them as we go on. People will talk about some of this.
Yeah, I think we have lost Professor Musisi again. I don't know. What's the next slide remaining? I think we have run short of time already. I think we need to move to the next presenter. That's what I would advise. Yeah, I guess so. We have seen what was there in that slide. Okay, so let me introduce the next speaker now. The next speaker is Dr. Janet Nakigude, who is affiliated with Makerere University as a lecturer in clinical psychology. She's going to talk about cognitive testing for dementia in Uganda. She's a behavioral sciences lecturer, as I said, at Makerere University, and she mentors students in behavioral science and bioethics, and has psychological assessment initiatives in Uganda National Referral Hospitals. She was a Johns Hopkins Faculty African Bioethics Training Program awardee and serves as a local focal person in the Africa Ethics Working Group. So, colleagues, this is now Dr. Janet Nakigude's turn. Thank you.
Thank you very much for the introduction. I have a passion. Good morning to you all. Good morning, colleagues, and good afternoon, African colleagues. I have a passion for taking care of the elderly, because that's where we're all ending and going. And so I have a special interest in neurocognitive testing. And as a result, we sat down with Professor Segani Musisi, Noeli Nakasuja, Professor Sewankambo, and we decided to come up with, we wanted to keep on doing neurotesting, but we hypothesized that through neurocognitive testing, we could actually assess the severity of the symptoms of patients with Alzheimer's and other related dementias, in as how much they impact on the distress of their caregivers. So that's just an overview, please. Next slide. Next, please. So I am not going to talk about the background because it's about what Alzheimer's disease is and the dementias, and we all have looked at that. Next slide, please. And I would like to put in a word for the caregiver burden. Sometimes when we have relatives, loved ones with dementia, sometimes it's very difficult for outsiders to start thinking through and mindfully reflecting on what the caregivers are going through. But it's such a burden to have a relative with dementia. Research shows that it is more burdensome. It's like three times harder for a caregiver to look after an individual with dementia than to look after someone who has a physical illness. Next slide, please. So we decided we wanted to correlate and see if caregiver burden increases with severity of symptoms. So this is our problem statement. Next slide, please. So our aim was to determine the caregiver burden and patient symptom correlates of Alzheimer's disease and other related dementia, which we've talked about. Next slide, please. So we had three objectives. We wanted to determine the caregiver burden of informal caregivers, and then we wanted to describe the patient clinical presentations. That's where the neurocognitive testing comes in. We used, we're going to talk about the tools that we used in assessing for cognition, for behavior, and functional symptoms. And we wanted to correlate caregiver burden with patient cognitive, behavioral, and functional symptoms. Next slide, please. So this is about the significance. We thought that if we could ascertain that the severity of symptoms in dementia through cognitive testing would actually point to the kind and severity of distress in caregivers, then we would probably come up with interventions that are going to focus on severity of patient symptoms as it relates to severity of distress in the caregivers. Next slide, please. So this is a conceptual framework that we used. We used the Lazarus and Folkman transactional stress theory. And this is about how we internalized this was that the severity of the patient symptoms, including the cognitive decline, the behavioral symptoms, the functional symptoms, would actually determine how distressed a caregiver would become, including the caregiver suffering from depression and anxiety. But of course, this also would be determined by the caregiver's appraisal of the stressors and the inner resources that they have to be able to take care of their loved ones. Next slide, please. Next slide, please. Next slide. Okay, so this was a cross-sectional study that we attempted to work on, and it had quantitative data collection and analysis methods. We did this study in central Uganda, in Wachiso district, and we have a sampling framework from which we picked the patients with Alzheimer's. So they all Alzheimer's and dementia. other related dementias. So we already had this cohort of individuals that we are following up in a longitudinal study, and we all know that they have neurocognitive disorders. So we paired them with their caregivers, and then next slide, please. That was the sample size. We had 113 dyads of caregivers and their relatives who were affected by dementia. Next slide, please. These are the tools that we used. We used the Addenbrooke's cognitive assessment tool that we are also using in the clinic to assess for severity of dementia, cognitive decline. Then we also use the neuropsychiatric inventory for behavior and psychological symptoms. We are aware that as patients continue to deteriorate, they'll commonly present with behavioral and psychological symptoms that may be very distressing to the caregivers. And then we use the Zarit caregiver burden inventory that has been culturally adapted to our Ugandan setting. Next slide, please. So we recruited caregivers. We already had the cohort of the patients, and then we obtained informed consent from some of the patients, from some of the relatives that had dementia. We also obtained informed consent by proxy for patients who were not in position to determine whether they wanted to be in the study or not. And then, yes, next slide, please. We obtained ethical approval from the Uganda National Council of Science and Technology and from the School of Medicine, IRB. We obtained administrative clearance from the districts. And yes, next slide, please. So we made sure that all questionnaires were reviewed on a daily basis to ensure that they were all complete, and we entered them into a data manager. We were able to summarize the descriptive statistics, and we analyzed for the means of the symptoms in the patients and also the distress of this, the distress in the caregivers. Next slide, please. This slide shows the characteristics of the participants. This has already been alluded to by Professor Musisi. The relationships of the caregivers, we had spouses, we had children, and we had grandchildren, and then we had others. And then many of them had none or very little education, but some had some secondary education and tertiary education. Many of them were employed, and of course they had gone to school. Some had gone to school, some had not. Patients, the majority of them were retired, because we know that if it's not secondary, if you're not talking about secondary dementia, we are talking about primary dementia, like Professor Segani has pointed out. The majority of people who are going to have this kind of dementia are going to be in their old age, and many of them are going to be retired. Next slide, please. Next slide. Okay, so sorry. We used these are the tools that we used. We used the Addenbrooke, we used the Zarit, and then we ranked and correlated the caregiver burden with the patient's domain symptoms using the Spearman's rank correlation coefficients. And then we analyzed for with a determined p-value of less than 0.05. Next slide, please. So this is for the Addenbrook. The Addenbrook is a cognitive assessment tool that we are using in our practice. And these were the means of the domains that we assessed for. We assessed for attention and orientation, because we know that as progressively the dementia increases, our attention and orientation becomes very dysfunctional and disrupted. Then memory is another one. Fluency was another domain. It becomes very difficult for patients to fluently change, come up with words that they need to come up with promptly. And then there was language, and then the visual spatial. Next slide, please. So then this was another tool that we used this to obtain these results. We used the neuropsychiatric inventory for behavioral and psychological symptoms of dementia. And we looked at delusions, where patients will have ideas that are so bizarre, and even when they are educated, you find that they're not in line with their level of education. This tool also looks at hallucinations, agitation, aggression, dysphoria, depression, anxiety, apathy, indifference, disinhibition, irritability, nighttime behavior, and appetite. And we looked at the means of all these behavioral and psychological symptoms of dementia. We're still looking at symptoms in the patients. Next slide, please. So then we now start looking at the distress in the caregivers. We use the Zurich caregiver burden. It has been culturally adopted in Uganda. And with this, now this was before we correlated the distress of the caregivers with the symptoms that we have looked at in the previous slides. So on the Zurich caregiver burden scale, about 57% of the caregivers reported little or no burden. Then about 36.2 reported mild to moderate distress burden, and about 6.7% of the caregivers reported moderate to severe burden. The numbers might seem very small, but if you are the individual who's going through this, then it's really a big deal. Next slide, please. Next slide, please. Next slide. Okay, I think the slides are not moving, but I think I have in my head. Okay, all right. So those are still the caregiver burden scores before we correlate them. Same thing. Let's go to the next slide, please. Next slide. Do something. Next slide. We should be looking at the correlation of the patient symptoms, their severity, and how this correlates with the caregiver burden. Next slide, please. The patient symptoms, the behavioral, and okay, now the slide down. I am sorry. So you see that in the first column, we showed the symptoms of the patients, and then in the rows, we're looking at the caregiver burden, and we indicate the Spearman's correlation, the Spearman's rank correlation, and we have significant, for example, delusion was highly correlated with distress in the caregivers, but it is also understandable, and they are the providers. You've been looking up to them, and then suddenly they are having delusions. They are hearing voices that others cannot hear. They are seeing things that they can only see themselves, but they also have bizarre ideas. So the delusions and the hallucinations were all significantly correlated with caregiver burden. Aggression was also highly correlated with caregiver burden. Very many times are aggressive, they'll get into fights. This may be verbal, they may be physical, but it's very difficult to relate with them and have them in their home. Then also, depression was something that was also very significant. Disinhibition was also significant. It was hard for especially the spouses to take this in. Imagine you have a spouse who's very respectable, and because they are disinhibited, sometimes they are going to undress, sometimes they are going to be vulgar in their speech, they're going to say things in front of children, in front of their grandchildren, and you just don't know how to handle this. So that was very, very distressing to the caregivers. Next slide, please.
Janet, can I request you to summarize, please? So
next slide, please. Yes, that's why I'm asking for another slide.
Thank you.
Okay. So caregiver burden correlated with severity patient domain, and that was our main aim. We wanted to see if the symptoms, the severity of the symptoms that the patients had would actually correlate with the caregiver burden, so that when we are planning, we can put this into summarizing. Well, so these also, we have the cognitive symptoms correlating highly with caregiver distress. We have attention and orientation and all those others. Okay, let's go to the conclusion. Next slide, please. Next slide, please. So this is, we already told you about our aim. There was a positive correlation between behavioral and psychological symptoms of delusions, hallucinations, agitation and aggression, and caregiver burden. So we think that interventions ought to focus on alleviating distress in caregivers with patients with delusions, hallucinations, aggression, and depression. And that when we're coming up with interventions, we should specifically focus on the symptoms that the patients have.
Okay.
The kind of and the severity, giving us the space to present this work. Dan, thank you.
Thank you so much, Dr. Janet.
Hello.
Yeah, thank you so much. We can hear you. I think there's a bit of a problem with your network. I guess maybe during this time, now that you have finished presenting, you can maybe sort that out. Maybe it may be important when you come during the discussion so that people can hear properly. Yeah. Yeah, but thank you for that interesting presentation. Now we're going to bring back Professor Musisi. He's going to talk about the challenges of dementia care in Uganda. So may I request you, Professor Musisi, please, I think on your area presentation, you did talk about some of the challenges. So maybe if you can just give it the specific challenges, maybe for 10 minutes so that we can catch up in terms of time. Thank you. Hello, is Professor Musisi here? Let's see.
Do you hear me?
Yes. Okay, we can hear you. Thank you so much. Yeah.
Next slide, please. Next slide, please. So, we're going to talk about the challenges of detection and diagnosis of dementia in Uganda. Next slide, please. The first challenge is that early presentation is often missed. Symptoms are often tolerated by families. They're covered up, they're hidden, they're feared for stigma, they're explained away, rationalized, or trivialized, or just accepted as people's ways, old people's ways. But early presentation seems to be more common in educated people with fewer children than those in the uneducated. Late presentation is the common rule. It follows disturbing behaviors or psychological symptoms of dementia, which Dr. Nachigude talked about. It often involves family arguments or aggression on part of the patient, or violence, or wandering away. Often, it may be associated with physical illnesses or multiple failed treatments. And also, people have different explanatory models for why the patient may be behaving that way, either religiously or culturally or socially. But sometimes they present because of legal problems, like land problems, banking problems, or problems about children arguing about wills and family arguments. Next slide, please. We also have challenges in history taking. Patients are often unable to give a history due to their impairment. Caretakers are often ignorant of dementia symptoms. Concerned relatives or children often live away or abroad. Relatives or children fear upsetting patients, especially patriarchs. Details are often missing, ignored, or forgotten, or trivialized. These patients usually have no medical records, but usually have come with a multiplicity of drugs. And many times, healthcare providers have missed the diagnosis. Family caretakers do not feel dementia is a disease, and therefore they don't care about giving treatment. And they tend, when they come, they tend to emphasize physical symptoms more than mental phenomenon. Next slide, please. So then we face challenges in examination. Few or often there are no personnel trained in dementia care or geriatrics. There are no psychologists or trained into cognitive testing, as we've heard from Dr. Nachigude. General healthcare providers are too focused on physical diseases only to care about mental issues. Other specialists try to treat dementias, like neurosurgeons. There are no social workers trained to do home assessments for geriatric patients. Lawyers and judges, when it comes to competence issues, have no appreciation of age-related cognitive decline or brain impairments or psychiatric illness in general. The few psychiatrists who are around, or psychologists, have no interest or skills in psychogeriatrics. And many times when they do medical examinations, they don't record mental phenomenon. Next slide, please. Then with investigations, biological inspections are expensive, they are few, and only found in urban areas. They must first discern all the various multiple causes of possible neuropsychiatric impairment, like other space-occupying lesions, infections, but missing dementia. The blood tests are also expensive. Imaging is very expensive and only available in urban areas. Psychological tests, which have validated the tools, are few, as we've heard from Dr. Nachigude. MOCA, ESHA, depression scales, and the rest. Like we have said, there are no geriatric social workers. And home assessments, we don't have people trained in doing home assessments. And our ambulances don't care for the special needs of the elderly. Next slide, please. What about the challenge of detection? We don't have appropriate assessment tools, which are culturally and contextually accepted and easy to use. So we tend to use multiple tools, which give multiple varying results. Like, for example, there are various prevalence rates in Uganda. Rural communities are served by village health teams. These village health teams or community health workers have no training in mental health or in dementia awareness.
We have left Steve. Professor Musisi again. Yeah, okay. We'll wait a bit and then see what happens here. How many slides are remaining again, please? Okay. So
Quite some bit, yeah.
For those having trouble with the internet, turning off the camera might work better.
Mm-hmm. Yeah. Well, I guess maybe us also as I guess all of us maybe we can try to turn off the cameras unless maybe when we are supposed to speak here. Dr. Paul, have you tried to reach out to Professor Musisi?
He's just started to rejoin. He just entered the waiting room.
Okay, thank you. Thank you.
Hello?
Hi there. We were just talking, maybe if you want to try turning your camera off to help with the connection.
Done.
Perfect.
Let's go to next slide. Next slide, please. So we did a small study in Wakiso elderly community to try to test the 1066 cognitive assessment toolkit for the detection of dementia among the elderly and to determine the prevalence of dementia among the elderly individuals. Next, please. Next. That is Wakiso district, which is around Kampala. Next. This was a cross-sectional study design, 500 population of people above 60, trying to test a toolkit, which consists of 3, the general practitioner assessment of cognition scale, the memory impairment screen, and the mini cog-TM scale. And we had all the necessary ESCO clearances. Next, please. Next. So we found a prevalence rate of dementia in people above 60 of almost 30%, 29.8. This is varying because other people using other instruments have found different rates. But it shows you that people above 60, many of them had dementia. Next, please. Next, please. Yes. The characteristics of these patients was that the dementia patients tended to have few social contacts, they had fewer children, and they had no friends in the community. Next slide, please. Then we tried to compare rural versus urban. And what we found was that in the urban areas, they tended to have more easier or quicker presentation compared to the rural, who were fewer. Females outnumbered the males, and they had less education. And HIB status was equally the same, both urban and rural. Next, please. Performance, rural versus urban, we found that in all the scores, the rural scored higher than the urban. Next, please. Next slide. Education levels we have talked about for the dementia. One is that dementia tended to increase with age.
I think we may have lost him again.
Yeah, we have lost him again. I don't know. I wonder how many slides are remaining. I guess the other thing is that if there is a colleague on the team, if they could finish off, I don't know. That is another way of looking at it. So
I wonder if just given the time of everything, we still have a few presentations to get through before the end of the session. If we maybe move on to the next.
yeah, okay. Thank you. I think let's show is a recorded presentation. So my colleague is gonna play that, but just briefly to talk about Rachel, she's a consultant psychologist at Jinja Regional Referral Hospital in Uganda. She is currently pursuing a PhD which is focusing on unmet needs of dementia caregivers in rural Uganda. Her research mainly focuses on people with old age and mental health problems. And she has also worked as a program manager for dementia-related research at the Makerere University, and also currently leads the mental health department at the Jinja Regional Hospital. So let's listen to the recorded presentation, please. Thank you.
Good evening, everyone. My name is Dr. Rachel Naito. I'm presenting on behalf of those co-authors, and I'm currently a PhD fellow on the CREATE PhD program. My PhD is on unmet needs of caregivers for older persons living with dementia within the Ugandan community. And I'll be presenting on work we did previously in a community setting, where we looked at reliability of utilizing community health workers in detecting and referring older persons with cognitive impairment for care in the community, because we know that the population of older people is expected to increase, and so is the population of people living with dementia, with Uganda alone having about 5% of its population aged 60 years and above. And we see that cognitive impairment is actually common in this population. However, it's often missed due to lack of knowledge and human resource. And within the Ugandan healthcare system, we have community health workers who are the first port of entry into the healthcare sector. And so this study sought to see how we would utilize them to include mental health in their training, and so be able to determine whether it's feasible to involve them in identifying and referring older people with cognitive impairment. So we had two objectives, generally to assess the feasibility of involving the community health workers in one, screening, and then two, in referring older persons with cognitive impairment for care within a Wakiso district in Uganda. So we conducted a sequential exploratory mixed method study. We collected both quantitative and qualitative data over 2 months. That's between December 2020 and February 2021. And the sample size was 385 older persons. And then we included those that had lived in the community for at least 6 years. And the community health workers had to be 18 years and above. Feasibility was measured as the ability of the community health workers to correctly identify and refer at least 60% of the cases with cognitive impairment. So we did administer a demographic questionnaire to the older persons and the community health workers. We screened for cognitive impairment using the Alzheimer's disease scale. And then also we used topic guides for focus group discussions, collect the qualitative data. So in each of the villages, we selected 12 villages, so we had 12 community health workers. So we did consent to the community health workers, collect their socio-demographic data, and then we did train them on cognitive impairment, its assessment, management, and the administration of the AD8. And then the PI and the research assistants. The research assistants were diploma holders in psychiatry or psychiatric assistants. And so these were the people that collected the data, or the experts, as we have called them in this study. So in each of the villages, the research assistants moved with the community health workers to assess the capacity for the older person to consent using the UBAC, obtained written informed consent. And then the community health workers did administer the AD8 to the persons, to the older persons, or the informer, or the informants of the older persons to screen for cognitive impairment. And whoever scored 2 and above on the AD8 was written for a referral note to be given to the psychiatric clinical officers or the diploma holders, who are our research assistants, or the PI, who was myself. And then the psychiatric clinical officers did administer the AD8 to all the older persons screened by the community health workers, regardless of their score. And at the end of the study, we conducted 6 focus group discussions, 2 for the older persons, 2 for the community health workers, and 2 for the informants, to further assess for the feasibility of the community health workers in identifying and referring the older persons. We analyzed quantitative data using Starter version 17, Then we conducted the CAPA statistics for agreements between the psychiatric clinical officers, who we have called experts, and the community health workers in screening for cognitive impairment, compared their raw scores using Bland-Altman and the pair plots, as we will see in the results. And our primary outcome was the percentage of older persons correctly screened and referred by the community health workers. The qualitative interviews were transcribed, translated, and thematically analyzed to further get the views of the participants on the feasibility of utilizing the community health workers. So in our results, the social demographic characteristics of the older person, we note that more than 70% were females with a marital status either married or cohabiting, an age range of mean age of 71, and the highest level of education were mostly primary education, and majority were either housewives or they had actually been unemployed. Regarding the social demographic characteristics for the community health workers, majority, more than 70%, again, were females, and said their level of education was mostly primary level or less, with a mean age of 51 years. And so I said we did the percentage CAPA agreement between the psychiatric clinical officers and the community health workers, and there was a 96.4% agreement in screening for cognitive impairment, with the clinical officers identifying 54 people as having cognitive impairment out of the 385, whereas the community health workers identified 58 out of the 385. And we also note that of the 58 that the community health workers identified as having cognitive impairment, they actually did refer 93% of them to the health facility, the nearest health facility where they are attached for further assessment and management. And we did note that there were more agreement between the community health workers and the psychiatric clinical officers for 88 scores that were below 2. There was a stronger agreement. And as I said, the Bland-Altman plot showed an almost perfect agreement within the 95% limits of agreement. From the qualitative results, looking at the feasibility of the community health workers in screening, we note that workers are more than willing to work with the older persons, given that they already work in these homes, only that they focus on young children and pregnant women. And then the community did acknowledge that they are port of entry into the community, and so they it was easy for them to actually access the community and be able to assess these older persons. And then we also see another sub-theme that emerged is that the community and most of the older persons respected the community health workers and held them in high regard and were more likely to accept any health information passed on by the community health workers, who also did provide psychosocial support for the families. Regarding the theme of feasibility in referring, different sub-themes emerged. We note that the community health workers are an important link to care, because in their training, they do have referral forms that they do give the people they assess in the community, the pregnant women, children with fever, and these enable them to be easily attended to at the health facilities. So the older persons felt this was an important link. If they have those referrals from the community health workers, then they're able to be attended to faster at the health facility. And most of the community health workers do follow up on the people they refer to see whether they accessed care. Yeah, they do follow up assessment. And then there was need for awareness and training needed to empower the community health workers, because their initial training focuses on child and maternal health, sanitation, hygiene, but not necessarily focusing on mental health or on older persons. So we note that more than 70% of the older persons were females. And this is comparable to the life expectancy in the Ugandan population, where the females have a higher life expectancy compared to the males. And the percentage agreement between the community health workers and the psychiatric clinical officers, who are our experts in screening for cognitive impairment, as we've noted, was 96.4. And this is in agreement to previous studies that have been done. As we have said, that community health workers have done a lot of work in the pediatric population. So a previous study done within the Ugandan setting showed an 86.6% agreement between a pediatrician and a community health worker classifying a fever as either a malaria or a pneumonia. And also noted that they were able to refer almost all that they assessed as having cognitive impairment. Again, in comparison with previous studies done on the continent, where they were able to refer mothers with infants and neonates who had febrile illness within the KwaZulu-Natal population. And as we noted, that there is need for empowerment, training, and facilitation, because most of their work is voluntary. So there is need to facilitate them to do this community work, but there is need for empowering them, continuous training on mental health, and more so on the adult population of older people. So we conclude that it is actually feasible to utilize the community health workers who are already available in the community, playing a linkage role between the community and the health facilities. So it's feasible to utilize them in screening and referring older persons with cognitive impairment, so that they receive a definitive diagnosis and treatment at the health facilities. There are unavailable resources that provide linkage of the older person to the health services, but they need continuous training and facilitation to carry on this role. Also note that further research is needed to replicate these findings in other settings, especially regarding the older population. Thank you very much. I acknowledge HEPI, Makerere University, and Washington University in St. Louis, who played a significant role in us conducting this work. Thank you.
We'll now move to the next presentation, which is going to be delivered by Dr. Paul Kiwanuka Mukiibi, who is the Executive Director of Uganda Alzheimer's Association. Dr. Paul has over 2 decades of experience in health policy, research, and technical assistance in public across multiple African countries. His work has influenced national health programs and policies in Uganda and the region. Dr. Paul is going to talk about informal caregivers' experiences for dementia in Uganda. Thank you, Dr. Paul. The floor is yours.
Thank you, Dr. Kennedy. Just to make sure that you know I'm not an AI image, a wave, but to protect the integrity of my connection, I'll now just go back to my picture. And Dr. Kennedy, as the session chair, I know that you're strict on time, so I've set my time and I've started it now. Next slide, please. As we go through this, a lot has already been said by the previous speakers, Professor Segane, Dr. Janet, and Dr. Rachel, that relates to what I'm saying. So I won't repeat what they were, but I will try and put it in together in the process of trying to expound what caregivers that we have come across have gone through. Now, I'd like to look at what I've called the factors affecting caregivers or drivers. The main ones that stuck out were stigma, lack of awareness and knowledge, access to medical care, care at home, and legal issues. As you know, these issues that have already been spoken about by the previous speakers, but what I'm going to do is highlight how individuals have been affected by them, as in their experiences. Next slide, please. Next slide, please. What we've found is that regardless of socioeconomic and educational background, traditional beliefs that have been mentioned, like witchcraft, as Dr. Reed mentioned at the start, are still there. Well, the reason why I said often stated is here I'm making a reference to those who are more educated, some of them highly educated. As Sir Garnet said earlier on, they don't actually look at dementia as a condition. Sometimes some of them don't look at it as a disease, and sometimes if those do look at it as a condition, they look at it as a special kind of madness that falls outside of the category of other psychiatric conditions that can be treated. One picks up on this during conversation. No one actually says it outright, but during conversation with caregivers, as they ask, could this be this? No, but how come? I've heard about witchcraft, witchcraft really works. So one begins to pick up that a lot of caregivers, and here I'm emphasizing highly educated caregivers, actually still hold at the back of their minds these beliefs. And then the other one is the issue of generational curses. Yes, prayer is an important thing, but this, and we, like many other African countries, are very religious. But when you look at the discussion of it being a generational curse, it's being looked at as from a religious point of view. And because of stigma, there is a very strong sense of shame amongst individuals. They feel that there is a stain on their family, and on the wider community, if they know, they feel that there's a stain on the community. Next slide. And these are things that I or people who have worked with have experienced talking in interacting with caregivers. Next slide, please. Now, as I was saying, what I've just discussed is not limited to rural setting or to those with lower level of formal education. Many think that it is, that only people who are uneducated and live in the village believe in generational curses or witchcraft. That's not the case. But anyway, moving on. Now, this stigma greatly affects health and help-seeking behavior. Here, I'll emphasize on the factor of help-seeking behavior. In Segane's last presentation, he talked about early presentation is often missed. Part of this, as he also pointed out, that it's amongst those who are more educated that early presentation comes through. But part of the missing, as he said, and as he implied, was because people don't want to admit to it. And that's why I'm talking about the help-seeking behavior. There's an internal refusal to do it until it becomes too late. And this is much more so amongst the older generation. Fortunately, one of the things that we're beginning to see in Uganda Alzheimer's Association, amongst those who are getting in touch with us, is people who are younger, let's say in their 40s, who are beginning to experience or to wonder about what the condition of their parents. They get in touch actually much more quickly and much more readily. But still, help-seeking behavior is greatly affected. Now, even after seeking medical help, it is still something that should neither be talked about nor acknowledged. You go, for example, for a consultation to Segane Musisi, or you've come through me, I've referred you somewhere else. One caregiver, a parent, a spouse or a child knows what is going on. Once they do find out, it takes quite some time before they start discussing it with others, perhaps even in their own family. Great effort is made to limit information within the nuclear family as much as possible. Needless to say, this brings a great deal of strain on the primary caregiver who's carrying this on themselves, or amongst later on those who feel that they're being left out. Next slide. Next slide. Now, we're looking at awareness and knowledge as one of the factors. Due to a lack of awareness and due to the prevailing belief systems I've spoken about, and this again has been alluded to by the other speakers, when one comes across the caregivers, they've already spent a great deal of time and money elsewhere, seeking informal medical help before seeking formal medical help. And a lot of this is from traditional medicine. I managed to attend one session yesterday and a tiny part of another, and this was talked about, and Segane spoke about it again. Now, traditional medicines or herbal medicines, alternative medicine, here and elsewhere in the world, it can be used positively or negatively. A lot of the time, before they come to formal, and this is where they admit it, before they come seeking for formal medical care, they've been going from herb to herb to herb, based on what somebody's friend's sister's mother's grandmother said. And they've been mixing them. If not that, it's healing by prayer. Again, there's nothing wrong with prayer. However, by the time many people present seeking formal medical care, they have spent a long time using prayer as the sole treatment, inverted commas. And in doing so, what goes with it a lot of the time is money. You have tithed, you have given offerings, etc., etc. So this continues to fall in with the whole matter of time being spent and money. And finally, there, as has been mentioned, is consultation with witch doctors. We don't have any figures on this, but we do know that belief in witchcraft and consultation with witch doctors, although not documented, is probably higher than a lot of people think. Next slide, please. Next slide, please. So unfortunately, even after seeking more formal medical care and treatment, many continue with the above treatments as if they are adjuncts, and which can have negative outcomes. The lack of knowledge, now that was awareness. Now talking about the knowledge, the lack of knowledge about the condition's progression also has a profound effect on caregivers. Again, this relates to the presentations that had been given earlier. And in this particular one, I refer mostly to what Segan had said in his first presentation. There's often denial during the early stages about the reality of the condition. As has been said, if caregivers' families get too much information at the same time, it is easier for denial. As he said, it should be staged in giving the information. But because once they do find out, and then they go to the internet and get an overload of download on what it is, there's often denial during the early stages about the reality of the condition, how it progresses. Next slide. And as has already been mentioned, because of these denials, caregivers don't plan. This is not just a research statistical thing. Caregivers do not plan, especially in our settings, socioeconomically in our countries, where planning for wills, even when you are well, is not at the forefront of one's mind. And because they deny it, and they deny the inevitable result, they're wholly unprepared for the effects of the progression of the condition. And this also relates to the legal issues. I'll say something briefly about that later on. Now, as the condition progresses, the sense of desperation increases. And I've seen caregivers who now again start doctor hopping. They get back to me and say they found someone else, they found someone else, they found someone else. They found this neurosurgeon, they found this neurologist. When they do say that, it takes some time to get them back to, let's say, get back to so-and-so who's being your primary specialist, because they actually do, apart from either being in this specialty or this specialty, whether psychiatrists or neurologists, they actually have expertise in Alzheimer's and dementia. But this takes time to get them around to. And because of this desperation, the doctor hopping, again, is very expensive and loses a great deal of time. Next slide. The level of awareness and knowledge. Now here we're still talking about, here we've moved about from awareness and knowledge to access to medical care. The level of awareness and knowledge about Alzheimer's disease and related dementia, ADRDs, amongst health workers is also still relatively low. As has already been said, many caregivers go through quite a number of medical practitioners who misdiagnose, or if they do have an inkling of the diagnosis, basically don't know how to handle it. And as Sagana said, their focus is basically on the symptoms, the prognosis, and treatment of comorbidities. You see, this next slide, please. By the time caregivers have gone through this, they end up very, very frustrated. They don't believe the medical system works. They no longer believe in doctors, and they've gone through a regimen of polypharmacy before referral for specialized care. They might be referred at some point by the first medical practitioner they come across, or at the point of where they finally get to someone, like sometimes when they call us. And I personally would say, okay, there's a choice, call so-and-so, 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 one of this lot. Before you do so, I'll give them a call to let you know they're going. By the time they do that, they've spent a lot of money. As Segane said, they come with a huge packet of medication that actually has no basis. And for this reason, many also, because of this, the fact that a lot of the first line medics who see them have little experience, many then go and look for psychosocial support and from guidance from outside the medical system, from family and community members, those who do decide to talk about it, one's religious community and the internet. When it comes to the family and community members, next slide, and one's religious and community leaders, this has the added disadvantage that a lot of the time they're given wrong information and conflicting information, and this confuses them even further. By the time they're referred to the right specialists, they're very often very wary and even mistrustful of medical practitioners. So what then happens is that that specialist initially has to start regaining trust, not trust for themselves, but trust for the fact that the medical practicing will be able to help them to XY extent, and then wean them off the misinformation they're being given and only tell them the truth, which, needless to say, they still don't want to hear. However, when caregivers' loved ones are finally seen by an experienced specialist, the number of times I have been given callbacks to say, oh my goodness, oh, thank you so much. This person has changed our lives. The gratefulness and the grateful relief is palpable. Again, access to medical care, needless to say, financial capacity is another key constraint. I'm not going to go too much into that. We all know, regardless of whether it is cancer or Alzheimer's or this or that, financial capacity or lack thereof, especially in the African setting, when there are catastrophic occurrences, can completely break up families. And this is one of the constraints to accessing proper care. Next slide, please. And then it comes to care at home, or as one of Segana's slides has put it, is where do you get their care? There's care at home, there's care in hospices, there's care here. The majority still opt for care at home. When we look at yesterday's presentations, I think it was Dr. Eve Namisango who had given a presentation and actually said that one of the differences that was seen between Uganda and Malawi, in Malawi, at the end of care or patients with cancer, many of them said that they would want their end of care to happen in the hospital, but in Uganda, the vast majority still stay at home. Now, care for Alzheimer's disease and related dementias, most of the people you come across, the care is taking place at home. And this is where the majority of caregivers experience the greatest difficulty, especially as the condition progresses. As we've already said, stigma dictates that speak not. So caregivers often end up alone. Looking after a loved one on a day-to-day basis is extraordinarily taxing. The list that Dr. Janet went through on the Spearman's rank correlation and what the research has been showing actually is really what goes on even at an individual cases. In case I have come across cases personally that because due to the strain on the family or the person looking after a patient, I've seen marriages break up of the children who are looking after parents. Next slide, please. Caregivers themselves begin to feel that it is a must that they put themselves second. When I talk to caregivers, when they come to me and the sense of guilt when they say, I can't handle this, I've had enough. One of the things I put across is you have to learn how to give yourself space. Carve out a time that belongs to you and keep that time religiously. Find someone who can step in, but you must have a life. Not only because in the end, the person, there is no cure. In the end, there is an inevitable outcome. At the end of it, what are you going to do? Are you going to have no marriage left? Are you going to have no life left? You must learn how not to put yourself second. Put yourself first alongside with whomever you're looking after. As I said, there's a profound sense of guilt. For the feeling of anger of having to be there all the time. There's also a profound sense of guilt, and this one sees more amongst spouses, especially the male spouses who stay. As again I pointed out, mainly it is the female spouses who look after. It's rarer for the male spouses, but for the male spouses who stay, there's a profound sense of guilt because they do not know what to do. And this sense of guilt actually affects them physically. I personally can give an example. I can't remember what stage related to my mother, this had happened. But my wife once told my father, her father-in-law, and as we all know, you don't go around admonishing parents-in-law in our culture, but she sat him down and basically said, if you don't get a hold of yourself, you will die before her. Not you may, you will. He was a shell of himself. She was one of the people who said, you know what, you need to find a way of actually looking after yourself. But this is the case where by the time my mother died, they had been married for 55 years. He did not know how to function without her. The good thing is, in my family, many of us were medical. For those who aren't, I've seen examples where there's someone who's a professor on campus. He did not know how to communicate with his children about what he was going through. And because of that, a breakdown has started to occur in the family between the father, as I said, a professor in Makere, and his grown sons. As the condition progresses, this comes to comorbidities which have been mentioned. There are some that have to be treated, but then there's also the stage where everything becomes an emergency. Your loved one who has Alzheimer's sneezes, everybody in the house freaks out and decides that sneeze means it's the end of it. I'm not sure why that happens, but it happens. Next slide, please. And then because of that, again, the strain on those who are giving care increases. Then there's also the real and imagined whisperings of others. I say real and imagined. Sometimes it isn't there, but then a lot of the time, extended family members start commenting about how, especially as we get towards the end stages, start commenting about how this person or this family has failed to look after their loved one. Because they don't know about the progression. There's a sense of guilt where I've come across someone who looked after her father. And years after her father had passed away, she came to me and said, I am still guilty because I mistreated him. She said, how? I asked her how, and she said, he lost so much weight. All of a sudden, it means I wasn't looking after him. I wasn't feeding him. Until I told her, no, that is part of the progression. Until I showed her some of the photographs of my mother when she could still walk, and as a doctor and a friend, it was only, and this was years later, it was only after our discussions when she realized, oh, it wasn't my fault. So situations like this become particularly disheartening, and they often lead, as I said, to breakdown in family relationships, not necessarily the nuclear family, but the extended family. Physical, emotional strain and financial burden is overwhelming. We all know that. And family members, especially children who live abroad, are expected to shoulder the financial burden. As has been said in some of the other presentations, we're beginning to find the situation, especially in the urban and amongst more educated, where the families are spread out. Regardless of their difficulties, more and more assumption is being made on family members outside the country to shoulder the financial burden. But not only the financial burden, increasingly I've been having people calling me from abroad, from as close as the DRC and as far as the US or Canada. It's not only the financial burden, they actually do become a lead caregiver, believe it or not. You see, they are looking after their family members here, and they are looking after getting it going, and they have to fly in. So that's something else that's beginning to happen. They seek help more quickly, but the burden of becoming almost a primary caregiver from outside is a reality, and this is very difficult on the families. Next slide, please. Next slide. So legal issues. Again, this has also been mentioned earlier on in one of the presentations. It has become increasingly apparent that caregivers, and I'm saying this increasingly apparent because I'm coming across more and more individuals, caregivers, especially children and wives, are at risk of losing property. Here I'm talking about not one, but giving a synopsis of examples I've been involved in. Family members are known to take advantage of the person affected by Alzheimer's disease and to get them to sign off property. They do this often in cahoots with someone or the other amongst the authorities, because they realize that this can be a really quick big maker. So they do it in connivance with someone in the authorities, and when they find out, it's very difficult to seek redress because of the connivance with the authorities. Again, giving an example, as my mother's condition progressed, and I was talking about denial, or you being with a partner and you simply think you are being disloyal. It was I who got to the point, and at one point told my father, you have to get to the bank. It's a must now. You have to get to they had always had joint bank accounts. I had never seen them without joint bank accounts, of which she would operate the house joint bank account. And that's what I'd always seen in my life. So I told him, you have to go and cut her off the bank accounts. No, I can't, etc., etc. I said, look, anybody can turn up and make her sign. etc., you have to start taking measures in this manner. And then talking about some of the other conditions that Janet went through that on the scale that affect caregivers when it comes to the aggression. There was a point where I told my father, of course, he ignored me until he got a call from my sister, my younger sister, but we all know the power of only daughters, where we told him that you have to move her out of the bedroom because this is becoming dangerous. And he resisted this for quite a long time, as I said, until she called him. So there's, as in summary, it's a very, very difficult thing for caregivers. As Janet said, it's been found to be 3 times more difficult than physical conditions to look after loved ones with Alzheimer's disease and related dementias. But somehow it has to be done, and they have to be given support. Next slide. That's my final one, I believe. My thank you. Okay, now here I just want to give a very, if you allow me, Dr. Kennedy, a very brief run through about the Uganda Alzheimer's Association. This will be quick. There only. Next slide. Okay, Uganda Alzheimer's Association is non-profit. It was formed by affected caregivers, medical professionals, supporters. Some of them are on the board. Segane is on the board. Janet's on the board. Noeline Nakasuja is on the board. Segane, myself, my father, etc. are some of the founding members. So we got together and said, no, what do we do in order to at least help people? Our mission is to improve the quality of life of all affected by Alzheimer's, and our overall objective is to reduce the impact of Alzheimer's disease and other dementias in Uganda. Next slide. Next slide quickly goes through what we do, our scope: support family caregivers and communities. We want to kickstart and get really running support groups through the country, promote expansion and access of treatment. And part of this is, as has been said, training healthcare personnel and also giving them awareness, raising awareness, combat stigma. Next slide. Next slide, please. Advocate for the establishment of a national Alzheimer's and dementia strategy. I've already started discussion on that with the Ministry of Health. Part of our agreement so far is that rather than getting at Alzheimer's and dementia strategy, as we already have a mental health strategy, that they're agreeable that under that we can then have an action plan for dementia. Part of the reason why under the mental health strategy is because dementia falls under the mental health bracket in the WHO. So we've already had discussions with the Ministry of Health and with the WHO. Apart from that, we want to coordinate Alzheimer's disease research. We don't want to be the researchers, but get to a stage where we're coordinating the research and possibly helping them to get resources and also to coordinate national and international bodies. Next slide. Very quickly, some of the things we have done. Here's an example. During COVID lockdown, the Ugandans over here would know that a lot of politicians turned up because it was very difficult. We had a severe lockdown. Politicians would turn up with trucks full of food and dump it into a square and call people to feed. What I did notice at the time on watching the news was the only people who got the food were the biggest and the strongest men, young men. And we realized that those who were most vulnerable, who were the elderly in the area, were not getting access. Okay, I'm a chairman of a local council. So in this area, I got young people from 18 zones, in the 18 local council zones, to go through those and say, can you please go and map out all the elderly? After you've done that, map out the elderly who do not have support from family members. And rather than dumping food, we went and then started talking to the small shop owners and saying that, how much would you charge for a small package of posho, that is maize flour, beans, etc. They said XYZ amount. We created a voucher, which you can see in the middle. We gave them to these elderly people who would then be able to go to that shopkeeper and would be given that package. The shopkeeper would redeem that voucher through us, Pepsi Cola Village, that's the Urban Council, that's the one that I'm the chair of, and Uganda Alzheimer's. So throughout the whole of COVID, we actually did this for the elderly in 18 different local council areas. Next slide. The other things we've done, we also had a memory walk in 2021, but you can run through those slides quickly. That was during the lockdown era. So because of that, we needed to seek permission in order to continue with those slides. We needed to seek permission. The slides are mostly of younger people. I think this is because we're coming towards the end. Just stop there a sec, reverse, just go back. As you can see, if you go back 2 slides, go back one more slide. As you can see in that slide, at one point as we were coming to the end, the anti-riot police turned up to find out how come, why are you congregating, and do you have permission? I have to admit it was probably because the color for Alzheimer's disease is purple, and a new political party with the same colors had just started, so maybe they made the assumption that we're hosting a political rally. Go forward, next slide. This was when he came to the end of the walk. You can see the shortest person there at the time must have been around 5, and he is standing next to the oldest person on the walk, who was 83. Next slide. Next slide. And of course, Alzheimer's and Uganda Alzheimer's Association focuses on the elderly. But how can you focus on only the elderly who worked so hard to leave something for the younger people? So this is also part of the work that we do to support others. In this particular case, we were given a rather nice plaque. That what you see there is mounted on some really, really good looking wood. I have it in my office, and we're given a commendation and for our contribution and support of World Polio Day in 2022. Next slide. This should be the end. And thank you. Thank you, Dr. Kennedy, for not cutting me off, and thank you all for listening to me. That's it.
Thank you so much, Dr. Paul, for that presentation. I was going to ask a question about how are you influencing policy, but I think that presentation or discussion about your work with the Alzheimer's Society has answered that question. So thank you so much. So for that reason, I'm going to invite the next speaker, who is Dr. Akusau Amangi from University of Ghana, who is a senior lecturer in aging. So briefly, Dr. Amiang holds a PhD in social work from the University of Ghana and has over 37 years of experience in social work, community development, and elderly care. So her talk will be on aging. So next presenter, Dr. Amiang, please.
You're muted, Epson.
Hello. So for the next presenter, I'm not sure if we...
Okay, so my screen is showing.
Yes, we can see your slides. Can you put it in a presentation mode, please?
All right. All right, thank you very much, Mr. Moderator, for this. And thank you all the earlier presenters. So my presentation topic is aging in Ghana. And a lot of the information that I have in this presentation has already been spoken about by earlier presenters. So I'll do my best to cut some of those information down. So this is just the outline of my presentation. So by way of introduction, all of us are aware that globally countries and people are aging. And so population is rapidly aging, with projections indicating about 16% of the world's population. And this has to do with the number of people that are turning 65 and older. And Africa, that Ghana is also a part, traditionally is characterized by a young population. but that is also increasing steadily. So Africa is also experiencing an increase in the proportion of older adults due to declining fertility and mortality, rates. And in 2010, 36 million older adults, 65 and older, made up about 3.6% of Africans' population, increasing from 3.3% a decade prior. Then the percentage of older adults has steadily grown over the past 40 years, rising from 3.1% in 1980. And so fast forward to 2050, the number of older Africans is projected to be more than triple to 235.1 million, surpassing Latin America, Northern America, and approximating that of Europe. Now, if that is the indications of the increase, then what is aging in Ghana? And who is considered an older person or older in Ghana? Now, in the Ghanaian context, aging is seen as a manifold process covering chronological, social, functional, and psychological dimensions, such that per that explanation, you may even be a 15-year-old person, but if you are very familiar with our culture, the social norms, and you function very well, you are responsible and all that, you can be considered as an older person. And so the Ghanaian government defines an older person as someone aged 60 years and above, aligning with United Nations and African Union standards. But socially in Ghana, aging is associated with the accumulation of wisdom and experience. Elders are revered for their guidance and leadership within communities. And this respect is encapsulated in the Akan proverb. We have a proverb in Akan in Ghana here that says, and I'm just trying to translate it literally in English, if a child knows how to wash his or her hands, he eats with older persons. So this is what we have. And in my local language, and when a child learns how to wash his or her hands, he eats with adults. So that is the meaning of the adage. So functionally, aging involves a gradual decline in physical and psychological capacities affecting daily activities. And this decline leads to disabilities, impacting an individual's ability to perform tasks independently. Psychologically, aging involves changes in cognitive functions and emotional well-being. However, in the Ghanaian context, exhibiting maturity and intelligence can lead to being regarded with the respect typically afforded to older individuals, regardless of one's actual age. So if you look at the proportion of population aging in Ghana, it's stated by research that those 60 years and above are increasing from 4.9 in 1960 to 7.2% in 2000, with projections reaching 9.8 by 2050. And according to the Ghana Statistical Service Population and Housing Census of 2021, the elderly population has grown nearly tenfold over the past 6 decades, rising from approximately 213,477 in 1960 to nearly 2 million in 2021. And many of these older adults live in rural areas and face numerous challenges, largely due to higher poverty rates and limited access to essential services. And so aging presents social, economic, and healthcare challenges, particularly in the middle-income countries like us, Ghanaians. There's an increasing burden of non-communicable diseases and dementia among older adults. Ghana's healthcare system remains largely focused on communicable diseases, leaving gaps in geriatric and palliative care. Now, the traditional extended family support system that once provided care for older adults is weakening. There are so many cracks due to some of the factors that other presenters have raised, such as urbanization, migration, and modernization, so that the extended family is not bonded anymore, where you can have an older person in the family and any family member can take it up upon himself or herself to take care of this older person. So research on aging, including its impact on family structures and elder care, and provide data-driven insights to inform policymakers, healthcare professionals, and social workers in developing effective community-based interventions, social policies, and government programs that support older adults. The Center for Aging Studies at the University of Ghana is now at the forefront of advancing aging research, offering evidence-based, solutions through one, exploring issues such as dementia, healthcare accessibility, and the psychosocial challenges faced by the elderly, training professionals in geriatric care, and developing educational programs to address, aging challenges, and then engaging stakeholders to influence policies that support older adults in Ghana. And these are done in tandem with what the Department of Social Work, the University of Ghana does as far as caregiving is concerned. Now, some of the key areas of CEPHAS in aging research and advocacy includes CEPHAS conveys over 150 key stakeholders, including representatives from government agencies, aging associations, healthcare providers, and academia to discuss elderly rights, access to healthcare, and strategies to improve the quality of life for older persons in Ghana. Again, CEPHAS, in partnership with donors, has provided essential healthcare items such as adult diapers, wheelchairs, walking aids, or to organizations supporting older adults. Now let's look at the traditional perspectives on aging. In the Ghanaian society, older adults were historically, revered as custodians of wisdom and cultural heritage. The extended family, as I said earlier, provided strong social support, ensuring that elders were cared for by younger generations. However, modernization, urbanization, and globalization, westernization, religion, so many factors have weakened family support systems, leading to increased social isolation among older adults in Ghana and in Africa. Why are there changes, and how are the changes taking place? So migration of the younger generations to urban centers or abroad, like Paul mentioned, has resulted in the left behind phenomenon, where older adults remain in rural areas without adequate support. Remember, we established the fact that we have about 75% of older persons in our rural communities in Ghana here. Then the emergence of nuclear family structures has also reduced the traditional caregiving role of extended family. So sometimes in the nuclear family systems, children are not even familiar or aware of their parents, because we don't send them to our communities. So they don't know them. Now we are going more nuclear than the extended family that existed. Women who traditionally served as primary caregivers are increasingly engaged in formal employment, affecting caregiving patterns. They are also migrating, and they're also going to school. Now it's even difficult for a family, whether nuclear or extended, to get a young girl or lady in that family to give care. So there's nothing like maid servants, in quote unquote, or house helps anymore. All of them are going to school. Those who are not, they do this for pay. Now, let's look at the health challenges, in the Ghanaian context. As Ghana's elderly population grows, the burden of mental health and non-communicable diseases among older adults has also become very significant. And however, Ghana's healthcare system remains slightly underprepared for rising health demands of the elderly. Now, if you look at the mental health challenges, it's a critical yet often overlooked aspect of aging in Ghana. Many elderly individuals suffer from undiagnosed mental health conditions due to cultural misconceptions and inadequate psychiatric services. The most common mental health challenge among older adults include dementia and Alzheimer's diseases, depression and anxiety disorders, and then social withdrawal. So, for example, dementia that all of us are talking about, I'm not going to dwell more here. It's a cross-sectional study that was done, and 16% prevalence was found among individuals aged 60 and above, with age, education, and employment status identified as key risk factors. And another study reported a higher prevalence of 23.38%, with gender differences observed, 24.56% in females compared to 21.31% in males. What are some of the causes? Some of the causes include mistaken for normal aging or spiritual afflictions. When the older person is exhibiting some, signs of dementia, we take it as normal. It's aging. You are an older person, so there's nothing wrong. And sometimes, even in our medical centers, this is told. Oh, they will tell you, well, this is so because he's maybe 70, 80, 90 years. So we really don't place much emphasis on the signs that starts coming. Families may hide affected individuals due to cultural beliefs. And also because of stigma and stereotypes, some families will hide because they think that their older person is mad. And so sometimes it goes to denigrate their family of you having somebody who is a mad person in your family. So they don't place much emphasis on that, and then they hide the person exhibiting the signs. And then few memory clinics or specialized dementia care centers also exist in Ghana, so it's choked. And so if you don't want to go and queue and wait for a longer time, then you want to keep your older person in his or her condition. Now, in terms of depression in older adults, that one also is a key mental health issue among older people. And studies have also found that 37.8% of older adults in their study experience depression, with factors like religion, living status, and chronic illnesses contributing to this prevalence. And another study by Amu et al. Reported prevalence rates of 25.2% for depression among adults in Ghana. And what are the causes? Some of the causes were a breakdown of extended family support due to urban migration that we've talked about. Many older adults have no pension or financial security because a lot of them are in the informal sector. And then there's limited psychiatric care, particularly in the rural community. So these are also some of the causes, and not all of them, but some of the causes of the depression in older adults. And there's another mental health challenge, anxiety disorders and social withdrawal. And the causes are older adults fear being a burden on their family. Sometimes they are in this, they are very much sick in terms of anxiety and social withdrawal, but then they don't want to be seen as being a burden on their family. So they recoil into themselves or they withdraw. And then also anxiety is sometimes linked to supernatural causes rather than medical conditions. So even if you report, they'll think that there's somebody somewhere that is causing that, you are a witch, or there's a witch somewhere causing that. And so people are really not too good when they enter into this situation to report. And then there's also few recreational and social engagement programs that exist for the elderly in Ghana. In fact, we can even say that even those recreational centers that are here in Ghana presently are not even for older persons. It's not older person specific, but it's a general thing. And so if this older person can afford, the person goes, walkways and places where you can go for walks or exercise are not too much here. All the ones we have are just the general one that everybody partakes, but we don't have it as it is in the Western countries. Then in terms of the non-communicable diseases like hypertension and cardiovascular diseases, there are several older persons in Ghana that have them. And the causes include increased consumption of processed high sodium foods due to urbanization, reduced physical activity among older adults, especially in the urban settings, limited access to routine blood pressure monitoring, and early intervention in rural areas. And then many elderly Ghanaians struggling to afford antihypertensive and medications. Then in terms of diabetes, the causes increased consumption of refined carbohydrates and sugary beverages. And then also studies have indicated a higher genetic risk for diabetes among West Africans. And many cases go undetected due to poor screening practices and health-seeking behaviors. And many older Ghanaians also use herbal treatment. And that can also delay medical interventions. And they claim, yes, we have a whole herbal hospital here in Ghana. Some of those medications are good, and these days it's even used in the main hospitals. But majority of these older persons that are in the rural communities resort to these traditional medical treatments without maybe seeking the orthodox medicine as well. Then stroke is one of them, and it's a major cause of disability among older adults in Ghana, often resulting from untreated hypertension and diabetes. And the causes are that many patients seek care only after severe stroke symptoms appear. And few physiotherapy centers also exist for stroke recovery, which are also very expensive. It's not subsidized, so sometimes it's difficult for some of these older persons to have access to them. And then stroke is sometimes attributed to spiritual causes as well, leading to delays in seeking medical treatment. And so instead of taking this older person to the hospital, they are taken to the religious centers for prayers and for other, rituals to be performed. And then cancer is also one of them, as we heard yesterday. And some of the causes are lack of routine screening programs, leading to many cancers being diagnosed at late stages. There's limited oncology specialists and treatment centers. And many patients also opt for herbal treatment due to cultural beliefs and practices. And then the social isolation here, which is a very big one, that causes isolation and loneliness. There's increased urbanization and migration, and this have contributed to social isolation among older adults, leading to depression and other mental health issues, because now they used to live with their family, their children, their grandchildren. Because of globalization, urbanization, even when the children are close to them, everybody is on his or her tablet or phone. So communication or, interaction with these older persons is, very minimal among the youth and then the older persons. So you stay here. Sometimes we go bring our older persons to live with us in the urban centers, and then we use them as security and we go to work. So these are some of the things. And then there's also lack of structured community engagement programs for older adults. That also exacerbates loneliness and social exclusion. Then there's also elder abuse and neglect, that many cases go unreported due to cultural taboos and fear of social consequences. Now let's look at the overview of palliative. So the palliative care services in Ghana are limited, as I said earlier, with most services concentrated in the urban areas. Now, the few available palliative care facilities primarily focus on cancer patients, leaving other chronic conditions unaddressed. Hospice care remains undeveloped, and most end-of-life care is provided informally by family members. Now, let's look at the barriers to effective palliative and end-of-life. So we have the cultural beliefs. Death and dying remain sensitive topics, leading to reluctance to discuss end-of-life care preferences in Ghana. And many Ghanaians prefer to die at home rather than in the hospitals. But there are no formal home-based palliative care services to support caregivers. And then healthcare infrastructure is one of them. Limited geriatric and palliative care specialists hinder quality care for older adults. Economic constraints is also one of them, a barrier. Many older adults lack the financial resources to access formal healthcare services. And then misconceptions about palliative care. Some believe palliative care is only for cancer patients, while others see it as a death sentence. So once you are sent there, they will tell you the doctor that's, you go to this doctor and you die. So these are misconceptions. And so because of that, there's no improvement in terms of the quality of life of this person when the person goes to palliative. They won't even go at all. And unlike in the Western countries where palliative care is well integrated into healthcare, advocacy efforts in Ghana remain weak, leading to slow progress in palliative issues. Now, so what are some of the potential solutions? So it comes back to us, training social workers, community health workers, and healthcare professionals to provide home-based palliative care, which we do as social workers and Center for Aging Studies. We have started in a very small way. About 7 years ago, we have been doing this, addressing financial and policy barriers by expanding the National Health Insurance Scheme coverage to include essential palliative care services and increasing government funding for palliative care programs and research. And then also strengthening the National Aging Policy to include provisions for comprehensive palliative care and addressing myths and misconceptions about dementia and palliative care through a public awareness campaign. So the National Aging Policy, we're advocating all the time and every time that if it can be passed into, law so that it can be implemented for people to, come out with some of these problems, because there's a lot of challenges when it comes to the area of the elderly, even in education and advocacy, a lot of challenges, because we don't have a law backing us in our roles as social workers and caregivers. Then again, the role of the social protection program that we have. So Ghana has the Livelihood Empowerment Against Poverty program that provides cash transfers to vulnerable older adults. And the National Health Insurance Scheme covers some healthcare costs for older persons, but coverage gaps remain. And this is not even enough. Looking at the number of older persons, if you look at the population pyramid, the top is almost the same as the base. So the number of children and then the number of older persons are becoming almost equal. And the time may come, we may have a lot of older persons at the apex, and then the base will be shortened. So we need to have programs that can guide us in our performance or work with older persons. And then establishment of more geriatric clinics, like we have already some few of them in the big hospitals like Kolebu Teaching Hospital. We can have more of such in all the regional centers if government comes in to support. Then encouraging intergenerational programs to enhance elderly social inclusion, and also expanding community-based elderly care programs. That Center for Aging Studies is also trying to do. Then integrating palliative care in Ghana's healthcare system, increasing government and donor investment in hospice and palliative care services, and then conducting nationwide studies on the prevalence of dementia and other aging-related conditions, and developing policies based on empirical data to support older adults. Now, again, the elderly population is growing, as I said, leading to demographic shifts that require agent policy and social interventions. And so there's also increasing cases of dementia, non-communicable diseases, and mental health issues that highlight the need for better geriatric care and healthcare infrastructure. Social isolation, elder abuse, and the weakening of traditional family support systems due to modernization and migration are also major challenges when it comes to the elderly. And this is by way of conclusion. And then limited services, cultural barriers, and economic constraints hinder access to quality care for older adults. So while the National Aging Policy, the LEAP, and other healthcare initiatives exist, significant gaps remain in ensuring comprehensive elderly support. And so as part of our activities for Social Work Department, Center for Aging Studies, University of Ghana, and some, other department that comes to help us, these are some of the things, especially in the social life of these older persons. These are some of the things that we do in the area of older persons. We do a lot of donations, and then we have research. Now we have even enrolled, students we are having courses in PhD courses in aging, MA, MPhil courses in aging, and then weekend courses in aging. All these are ways and means of trying to, educate people to be able to be interested in the issues of aging so that they can take it up as policymakers. Some of them, when they end up becoming government officials or whatever, they can help. And some of them also, they are individuals that can come to us and help us in the area of the elderly when we do such things. We have several stakeholders that we work with. Tobinco Foundation, Mame Nursing Home, several, organizations that come to help us in terms of the work with the elderly that the Center for Aging Studies has taken upon itself. Currently, there are some donors that have also donated to us, and very soon we have a project called 100 wheelchairs that we are going to, distribute. And so these are some of the things that other individuals are helping us to do as a center. And so you are welcome and you are invited for questions and for to be part of us so that we can all champion the work of the elderly or aging in our community. Currently, we have our director, Professor Osafo, who really is into fundraising to help us have our structure, because we don't have a structure where we can do all the social activities. So we are trying to, sort of funding so that we can have that structure on campus, University of Ghana campus, to help with some of the social and health needs of these older persons. And so thank you very much for listening. This is the end of the presentation. Thank you. I await your questions. Thank you very much.
Thank you so much, Dr. Kusa, for that wonderful presentation. Thank you indeed. Yeah. We'll move on to the next presentation. This was supposed to be delivered by Dr. Jane Nabuleba Narubega. But unfortunately, she's not feeling well. However, Professor Musisi has said, well, I will deliver this presentation on her behalf. So please let us welcome back Professor Musisi, who's going to talk about using mobile outreach psychosocial services to improve elderly quality of life in Wakiso district in Uganda. Thank you.
Thank you. You hear me very well?
Yes, we can hear you very well. Thank
I
you.
hope the internet will be clear. Let's project the slides. So I'm going to present Dr. Jane Frank Nalubega's presentation, which is on using mobile outreach psychosocial services to improve the quality of life in Wakiso district, Uganda. And she did this as part of a randomized controlled trial, I think, for her PhD. I was her supervisor. Next slide, please. She gave a history of the world's population, which has been given by everybody, and I don't think that we should really belabor into going back into that. But the reality of it is that by 2050, the number of people living over 60 years will globally exceed the number of people, of younger persons less than 60 years by 2050. And an estimated 63% of this will be in developing countries. By 2050, totaling to about 1.5 billion older people, which will be residing in developing countries. Next slide, please. Uganda's population has been increasing. Those are all the statistics of 2002. We can quote annual statistics right now that we are about, we are almost 48 million people, and the percentage of people who are older is more than 5%, older than 60. Let's go on to the next slide, please. The problem is that as the population increases in age, it becomes a burden to governments and communities for their care. Older people tend to have more disease, and they tend to be poorer, and they're not able to work, they have less opportunities, and as has been stated by many speakers, the younger generation is moving into towns or abroad, and also in search of work, and spending less time with elderly people. Next slide, please. So the elderly people face a double burden. One, they have of replacing lost income while supporting again family members of those who have died, like for example, AIDS orphan grandchildren, and yet there are no formal responses to address their cares. In Uganda, we have the Senior Citizens Grant, but it does not really address social support, health and nutrition, and the money is very minimal and difficult to access. And there are no public awareness campaigns within communities to talk about the plight of the elderly. Next slide, please. So this study wanted to examine whether mobile outreach psychosocial service providers could be started to improve the quality of life of the elderly, and to examine whether or not their quality of life would improve by using these mobile outreach psychosocial services called MOPS to improve their both physical and mental health. Next slide, please. So it was hypothesized that the elderly in the intervention group, it was a case control study, will have significantly better post-intervention quality of life, and whether or not they'll have more social interactions in the community, and whether or not they'll be better off compared to the control group where there were no interventions by the MOPS. Next slide, please. The study was taken in Wakiso district, which we showed you before, where there's a prospective cohort of elderly people being followed up. And in that place, in Wakiso district, which is around Kampala, 4% of the population are above 60 years old. Let's go to the next slide, please. I think we have talked about that. We don't have to talk much about that study site. Next slide, please. So we included people 60 years and above, but excluded those who were in hospitals or in other healthcare institutions. We used the cluster sampling to cover the whole district, to cover the various sub-counties. Next slide, please. The tools that were used were the WHO Quality of Life Brief Outline to measure their quality of life, both quantitatively and qualitatively. We used focus group discussions, key informant interviews, and in-depth interviews. And we used a random control study for the quantitative studies using that WHO Quality of Life Brief instrument. Next slide, please. Pre-intervention, we recruited research assistants, had informed consent, trained our research assistants on the WHO Quality of Life questionnaire, which was used to generate both baseline data and follow-up data. Focus group discussions were conducted to generate qualitative data from the village leaders, and key informant interviews were conducted with specifically chosen NGO staff and district officials. Next slide, please. Recruitment and training of community geriatric volunteers into management and care for the elderly was done, and then reach out, home visits were done to collect the data from the community after conducting some kind of mobilization, sensitization about the care of the elderly. Calling these people who went in the community geriatric volunteers, who created awareness about the elderly and what we are going to be doing. Next slide, please. So we collected quantitative data, which we analyzed using SPSS and Pearson Conduct Product Moment for associations. And qualitative analysis was done using in vivo computer-assisted qualitative data analysis software called CAQDS. Next, please. Next, yes. So the key findings, quantitatively, the MOPS model improved all 4 quality of life domains. Environmental well-being contributed to the highest improvement in quality of life using home-based care. In other words, going to the elder people's homes and giving them care there. Social relations contributed least quality of life. We shall see the reasons for that. And those were the coefficients of associations, respectively. Let's go on to the next slide. Qualitatively, empowerment and there was realized empowerment and increased self-esteem among the elderly, feelings of control over their lives. They engaged more in psychosocial and economic support groups. There was a positive impact of the mobilization and sensitization done by the geriatric volunteers, community volunteers, and reminiscence groups were preferred. Reminiscent therapy means engaging the elderly in experiences they had before. For example, reminiscent music and dances. Next slide, please. So music as therapy has been shown to be effective for palliative and end-of-life care. Music was particularly beneficial for those in end-of-life care situations. It enables them to get relaxation and it is calming. It makes them tolerate pain better, and they feel a sense of well-being. Spiritual music was preferred by these elderly people. Next. Successes and challenges. Successes, there was not much resistance from the respondents by the involvement of the community geriatric volunteers, and we maintained confidentiality, which they were worried about. But the challenges realized were that there was too much expectation from the elderly about what was going to help them to live their otherwise difficult quality of life. Research assistants tended to want to have more roles to play than what they were actually trained to do. But VHTs or volunteer health teams, were sometimes difficult to train because they've been trained on physical illness, less so on mental illnesses. Unfortunately, one of the elderly group leaders was knocked down. It was a side effect realized, because communities don't necessarily care too much about elderly safety. And communities seem to be not very interested in elderly issues, partly because their relatives have moved away. Next slide, please. That is what that study showed. In essence, that involving mobile communities into communities to help the elderly is helpful to the elderly, and will be a source of referral not only for treatment, not only treatment, but also referral for expert care, and getting them again engaged in their communities. Thank you. That was Jen Francis Nalwega's presentation in summary.
Thank you. So that's you again, Professor.
Now this one
wind up.
is interesting. Because, and I would like a little bit more time here. I hope the internet will bear me out, because we realized that we had to do palliative care training for palliative psychiatry for our communities and our healthcare providers. And we tried to put up a program to train them, and we wanted to present to this group here about what we went through in terms of training for palliative care psychiatry. Let's go on to the next slide. So what is palliative psychiatry? One, the definition of palliative care is to improve the quality of life of the patient and the family through prevention, relief of pain, suffering, and misery, by early identification, assessment, and treatment of pain and the associated problems, psychologically, physically, socially, and spiritually. But psychiatry itself deals with mental illness, which is defined as psychological, emotional, and behavioral distressing symptoms which impair functioning in the individual. So trying to help those we felt was a natural consequence in palliative medicine. Palliative psychiatry, therefore, for terminal illness comes in to ensure comfort care, supportive care, symptom relief, and management by treating psychological, emotional, and behavioral distressing symptoms, but not, and enhancing quality of life. But it's not to prevent, to cure, or to hasten death, or to, yes. Next slide, please. Or to postpone death. Next slide, please. Next slide. Okay. So what are the common situations and conditions that
So that's very interesting that we can't hear Professor Musisi again. Okay, we'll give him a few minutes again. Yeah. Well, what do colleagues think? What if we swap his presentation? We can invite the next speaker so that maybe we can give him a bit of a break. I think the other presentation was quite okay. He delivered it quite well.
Yeah, and just due to time, that might make sense.
Yeah. Okay. I see that he's back again. Sorry, is he back again? Let me check. He is. Yeah, well, I guess with the interest of time, let me maybe invite the next speaker. So maybe Professor Musisi may carry on later. So the next speaker is Michael Jemba, who is going to talk about diet, nutrition, and dementia in Western Uganda. Briefly, let me talk about who Michael is. So he is an allied nutritionist with the Association of Uganda, and he has got over 6 years of experience working in nutrition implementation and delivering programs in a degree in human nutrition from Makerere University, and has worked with the hospitals such as the Mukano Church in Uganda, hospital in Hoima regional referral hospitals, and non-government organizations in Uganda. So, colleagues, let's have Michael Jemba for now. Thank you.
Hello, colleagues. Thank you so much. Can you see my screen?
Yes, yes. So do you want to put it on the presentation mode, please?
Gladly.
Thank you. So you can carry on. Thank you.
Okay, thank you so much. So greetings, and I appreciate this invite. I will go through very fast. So I'm going to present about diet and nutrition in Western Uganda. So I've already been introduced, and that's me. That's how I look. Glad to be here. So nutrition is usually not given so much time. I believe it's one of the challenges we face as nutritionists because it's a bit sidelined, and when problems come, they realize that it was actually nutrition that brought this problem. So let's go a bit into what happens. I know I'll try to go in all those directions, but let's go into what happens. So in Western Uganda, it's here in Uganda, it's called a food basket. It's where food comes from. You literally find food coming to Central Uganda, going to Northern Uganda, all coming from Western Uganda, yet that region experiences a lot of stunting. So stunting is just a term that means that these people are too short for their age. They literally have to be taller. And by being taller, I mean their body has to be built to a certain height, but they are still shorter. So on the side, you see an image of very young children who are short, and also their bones are showing some rickets. So we have such an area called the Western Uganda, which has a lot of food, but it faces malnutrition. Then there is some statistics that I would like to share with you. And this is, Uganda is among the East African countries, of course, but with a high level of undernutrition, whereby we have over 29%, or 3 in 10 children who are below 5 years of age stunted. That is alarming. That means that a generation of children below 5 years is going to grow up with incapacitation in their working, in their functioning, because stunting starts in the brain. So the moment you see a stunted child, that means their brain is the first that got stunted. It stopped growing. So it can't function to the proper way of functioning even later in life. Then there is an article that was written. It is the trends of child wasting and starting in Uganda from 1995 to 2016 and progress towards 65th World Health Assembly Global Nutrition Targets. Now, this one was published by one of my very close friends, Dr. Buzigi, and it was showing that the prevalence of stunting in 1995 was 38.3%. Now, this means that the generation of the children from 1995 are now working in offices, they are now in places of management, but since they were stunted back then, they can't perform well because, again, I told you stunting starts from the brain. So a generation below this, probably the one of 1980s, was probably stunted more, and one that was maybe in the 1970s faced even more stunting. Now you find that those are our elderlies right now, and I will show you in relation to this that if the elderly right now was stunted back then they are more likely to face some of the problems they are facing right now, dementia and some other conditions that we shall look at. Now, based on the statistics that we found from the Western Uganda, there are some factors, nutrition factors that influence dementia, of course, that we found on ground. Little documentation has been done, but some has been existing. So the nutrient consumption, of course, nutrition consumption is very key. Then waste accumulation, mainly in the brain. Then hippocampus damage, when that area of the brain that works with memory is damaged. Then nutrients that stimulate neuron growth decline when those nutrients reduce and they are not being replenished. Then absorption of brain enhancing, sorry about that mistake, enhancing nutrients. So we have nutrients that enhance the brain functioning, and we shall look at them. Then we have lysosomes atrophagy, and there is also one gene that can mutate that causes problems, the PSEN1, that when it mutates, it affects the autophagy of the lysosomes. Then we have neurodegeneration and neurogenesis. When you don't balance that, when your neurons are being damaged more than they are being replaced, then there will be a problem. Then we have fasting and also probiotics and sleep. So all those factors were there on ground, and we shall just take a look at it. Now, starting with diet. Studies performed in rats and mice demonstrate that high fats and high sugars have a negative effect on the adult hippocampal neurogenesis. So at a low level, when someone consumes more fats and more sugars, and we found out that some people in that area, the Western Uganda area, they are more into taking some of these fats. Yes, it's a remote area, but people like those chips and what mainly in Mbarara area, because Mbarara is more of a center area. Then the other ones deep in the areas, they literally don't even feed at all. They like playing around with food. Then it is in contrast with diets enriched with bioactive compounds such as polyphenols, then polyunsaturated fatty acids, as well as some intermittent fasting and calorie restriction. Now, these ones can induce adult hippocampal neurogenesis, that is AHN. So you have more neurons formed in your hippocampus. That means the hippocampus is being replenished with more ability to work even as someone ages. So different diets impacting the formation of neurons in your brain. And let's note that plasticity of new neurons is greater than that of adult neurons, just like the ability of someone to work. They work better when they are younger than when they are older. So we make sure that we have new neurons being formed and not reducing that. And that is totally impacted by nutrition. Now, taking a look at omega-3 fatty acids, especially docosahexaenoic acid, that is DHA. I believe with all that we've gone through here, we've mentioned some of that. So this one can increase autophagy. Now, it is present in fish, it is present in vegetable oils, it is present in nuts, flax seeds, and some others there. But let's understand that it is affecting the membrane fluidity. You know that there is a membrane, the blood-brain barrier, that barrier. Then that fluidity, we want it to be really good. So there is also improving the serotonin binding. So remember, serotonin is a neurotransmitter that stimulates neurogenesis and some other things like sleep and all that. So it improves serotonin binding. Then regulation of neutrophins. Now, neutrophins are just proteins. These ones, their levels For example, BDNF, since they are part of the structures of the membranes in the neurons. So regulating this formation and making it able to be part of those neurons makes more neurons being able to be made in the brain. So omega-3 fatty acids, there is more about them, but just that. Then we have folates. Now, folic acid is well known that the moment a person misses folic acid, even a deficiency of folic acid in a pregnant woman causes a neurotube effect. That is spina bifida. Now, how about when people do not take it over time? It is not just important during pregnancy, it is also important during growth and development, after birth, then people go in work, school, things like that. That is all folate. So an important part that regulates the central nervous system development, and it is present in dark green vegetables. Now, folate comes from the word foliage, which means green. So green leaf vegetables are abundant in folate. Then beans and peas and nuts. This plays a critical role in the maintenance of the DNA methylation and the epigenetic functions. So its deficiency diminishes the concentration of neurotransmitters in the hippocampus. That means it is going to affect the AHN, the adult hippocampal neurogenesis. So if you're deficient in it, then you will not have enough neurotransmitters, the concentration that will impact the formation of those neurons in the hippocampus. Then another vitamin is cobalamin, that is vitamin K. It is more in poultry and fish, but it's also existent in meat, eggs, and dairy products. Now, it is existent in all these, but preparation methods, mainly in the Western region, affect its availability. Remember, it's a fat-soluble vitamin. So many of these people don't know how to prepare this food. So even when they eat this food, they do not get what they need in the right amounts. So this also plays an important role in DNA replication and methylation. So its lack can impact the AHN. Now, we also have polyphenols. Polyphenols are a very big group of phytochemicals. Now, these ones are present in plant-based foods, and they are known for their biological, oxidative, and neuroprotective properties. Specifically, they are antioxidants. So they reduce some of the effects of free radicals. And in that way, they are going to protect your neurons from damage. So you hear what we call neurodegenerative. But when you come here, you're going to have neuroprotection. Neuroprotection, in other words, your neurons will be protected from damage from free radicals. So someone is at a higher risk of getting Alzheimer's disease, but when you eat well and you get enough antioxidants, examples polyphenols, you reduce the risk of getting some of those neurodegenerative diseases. So several studies suggest that polyphenols induce AHN. In other words, they increase the formation of new neurons in adult hippocampus, okay? So they also increase the synaptic plasticity. Now, the environment in which the new neurons will be made is now made favorable by these polyphenols. So you have the potential of the hippocampus having new neurons being made, and hence you enhance your learning and memory. That's why some people associate that with brain boosting, eating that food with brain boosting, but it's just helping you improve your memory centers so that they can function properly. Then you cannot talk about memory because memory is something big, and you don't talk about microbiota. Now, in the Western region, when we went on ground, there is some research that has showed that people by the adult age, they have never taken probiotics. Some of them don't take milk or yogurt, some sources of probiotics. Then they take so many antibiotics. So you end up with an adult person by the age of 30 years when they are already in dysbiosis. So we have this saying in nutrition that fix your gut to fix your brain. In other words, the gut is really connected to the brain, mainly via the vagus nerve. This allows the gut to influence mood, emotions, and cognitive functions, including memory. But even the brain affects the gut. So you'll have these microbiota, they will help you in reducing oxidative stress, because they secrete some of those compounds that are antioxidants. Then they also produce serotonin. Now, this is where some researchers really beefed up when they found out that most of the serotonin that is actually in our bodies is, and some other neurotransmitters, some of them come from the microbiota, the probiotics. When they secrete it, they can influence your mood, your sleep, and your memory. Then they also produce the short chain fatty acids, SCFA. Now, these ones will strengthen the blood-brain barrier. Remember, we do not want toxins to easily get through the brain. So the moment that barrier is well nourished, well laid out, it will prevent some of the toxins getting into the brain easily. So you'll have your memory well taken care of and not influenced by or affected by toxins. Then they also play a role in reducing inflammation. So they secrete some compounds that can reduce inflammations, especially these short chain fatty acids. Now, there is also inflammation in the brain that happens. That is encephalitis, I believe. So short chain fatty acids can reduce encephalitis, and that is because they are anti-inflammatory. And encephalitis can actually impact someone's memory. They can't really remember some of the things very well. So in a study in some mice, antibiotic administration decreased hippocampal neurogenesis and induced changes in their molecular signaling related to this process. So you find that antibiotics taken by so many people, they never replace those gut microbiota, but they are so important in nourishing, taking care of your brain and making that surety that it works well. So nevertheless, prebiotics, which is food for the probiotics, this was administered and it reversed the negative influence of antibiotics. Now, this study, I have a link to it in case someone is interested. It is really a very good study. So our gut and our brain are so connected that even with a certain lack of an amount of probiotics, it can directly impact your brain, mood, and anxiety and depression. That research is all there. So there is more about microbiota that it can do, but briefly, I wanted to just take it to that. Now, related to our Western region, many people do not replenish their microbiota, and we shall see that later in life, they are affected. So we also found that fasting is part of nutrition. So yes, we eat, but what we eat, there is time we take to eat it. And also that fasting, because you've heard about fasting blood sugar, what. So it's totally part of nutrition. You can't separate it. So different preclinical models reported that increased AHN in intermittent fasting or caloric restriction. So there is a lot of AHN, that is adult hippocampal neurogenesis. In other words, they are making neurons, especially when someone is fasting or they are restricting calories, that is CR. So caloric restriction models generally refer to 30 to 40% decrease in your calorie intake. So if you've been taking maybe 100%, you reduce it about 30 to 40%. That is intermittent caloric restriction and fasting. So there is also a strong consensus in the intermittent fasting and CR that they promote AHN. So this research is there that fasting helps you in increasing your neurogenesis in the hippocampus. So fasting also significantly increases autophagy. Autophagy, remember, it's this one is the cellular process where cells break down and recycle their own damaged components to generate energy and nutrients when experiencing some deprivation of calories, of course, food intake. Now, this is considered to some a survival mechanism, but we need this so badly. We need autophagy so badly. That's where the lysosomes in your brain, in your cells anywhere, deal with the waste, the damaged cells and those waste, and they break them down and process them into nutrients or new cell components. So you don't have waste accumulation, which is one of the components that trigger Alzheimer's disease. So waste accumulation is reduced by autophagy in the lysosomes. So we need this badly. And guess what increases it? Fasting. So intermittent fasting increases it. This is not fasting for all your day. So you just fast for a short period of time, or even just calorie restrict. You reduce on your calories. Then your body does what it is meant to do. So it helps these cells to function normally. Then the other thing you have is sleep. Now, it's called the glymphatic system. I hope I'm pronouncing it really well. On the right side, it's trying to show us the glymphatic system. Now, this is like the lymphatic system in the other parts of the body. So scientists believe that this network of pathways effectively flushes out those metabolic wastes. These ones are usually generated by the energy metabolism and all that. So they need to be flushed out, and the glymphatic system needs to do that. But of course, these wastes include amyloid and tau. So those ones usually even are associated with Alzheimer's disease when they are in big numbers. So the body usually flushes these wastes out in deep sleep. Whenever someone doesn't get deep sleep, whenever they don't get good sleep, the glymphatic system does not really work well to flush out some of these wastes. So it is important for someone to get good sleep, at least for 6 good hours. So you make sure that you sleep for 6 hours, then at least 4 hours, your body is at rest, and then it can flush out some of these wastes. Remember, nutrition involves eating, digesting, and flushing out. That's why it's not just about eating, but even when you're pushing it out, what you ate, it's part of nutrition. So even when the brain is feeding, it metabolizes and it also flushes out. Now, when you tamper or impair flushing out, you bring bad conditions, including dementia and Alzheimer's disease. So in the Western region, people don't sleep. People take alcohol even up to midnight as they are still jumping around. Then later, they take some little sleep and then they wake up so early, go to do their business. So having little sleep also affects their brain functioning later in life. So I'm trying to conclude with this because I know our time is already compromised. Calcium, you cannot talk about brain functioning and you do not talk about calcium. Calcium is facilitated by vitamin D. Its absorption is facilitated by vitamin D. And vitamin D is gotten from the sun, then it goes to the liver, then it goes to the kidneys, where it is finally metabolized to become the active form of vitamin D. And that one will be the one that will improve in calcium absorption in the body. So some people have liver disease, others have kidney disease. Then others are too old, their skins are no longer perfect at getting the vitamin D. So they compromise their body's calcium absorption because vitamin D cannot reach the last stage of being active to absorb calcium. But remember, I told you calcium is very important in the brain. So children, of course, they have some rickets and osteomalacia. Then adults have some osteoporosis. And it has been discovered that an adult with osteoporosis is more likely to have memory challenges or even dementia. So this is the relationship that during learning, there are synaptic transmissions of calcium. Now, calcium plays a key role in this area where it activates a protein called calcium, that is CAMK2. I'm forgetting the whole abbreviation. It's CAMK2. So it's activated by calcium in the brain, and it facilitates synaptic changes that encode memory. So if you don't have enough calcium, remember I told you most of the adults there are even already under osteoporosis. So their brains are already communicating that they don't have enough calcium, but calcium is also required in their memory registration. So you're having so many adults in the Western region forgetting because they don't have enough calcium, like they don't have enough calcium in their body. So they are not encoding good memories. Then the other thing you have to realize is that one of the doctors who presented, I believe it was the first professor who presented, he said women are more likely to face dementia than men. Their numbers are higher. Remember, women are more at risk of also losing their memory earlier because women carry children. Now, children take calcium from pregnancy, during breastfeeding, and also, I believe that is it. But pregnancy takes 9 months, and that child's muscles and some little tissues have to be put together. So there is extraction of calcium from that woman, and that woman during pregnancy usually faces some back problems, standing problems, joint pain. So calcium is usually a problem. Then during pregnancy, they take out that calcium. Now, breastfeeding, calcium is still taken out of a mother in breast milk. Remember, one of the biggest sources of calcium is milk and yogurt and dairy. So dairy. Then a mother breastfeeds for about 2 years. So in about 3 years, pregnancy of 9 months and breastfeeding for 2 years, a woman spends 3 years of calcium depletion on just one child. So if you have a minimum of 3 children, that is 9 years of calcium depletion. So if you do not replenish your calcium, you're going to end up with osteoporosis, which will end up having your brain not actually having enough calcium to encode memories. So these people end up, when they are adults and they have not replenished their calcium, they end up having remembering problems, forgetting problems, and all that. So this also happens in men because we don't feed well. As I told you, we might even eat the foods rich in some of these nutrients, but preparation methods are very poor. So with that said, I want to appreciate you considering nutrition to be part of your presentation. Thank you so much. Back to you, our moderator.
Thank you so much, Jemba. Professor Musisi, would like to come back and then finish your presentation, please?
Hello, Dr. Kennedy.
Hello?
Yes, again, jumping in. He's back. I'd had a call from Dr. Musisi earlier on, and he thought he wouldn't be able to make it. Welcome back, Sengani.
It's the internet.
Okay, do you want to conclude your presentation, please, Professor Musisi?
Yeah, I can continue because I was on the slide saying palliative psychiatry and pandemics. If you can get back to that.
Okay, thank you.
Do you hear me?
Yeah, I think my colleague is going to load your presentation.
Loud and clear.
Yes. So I was going to say that we saw an opportunity for palliative psychiatry and pandemics, examples of which we have had recently, like COVID-19, Ebola. Of course, we have always had HIV/AIDS, and recently monkeypox in Uganda. Ebola has come back. All of these pandemics are highly infectious, fatal, psychologically traumatic, causing uncertainty and fear, anxiety, feelings of helplessness and hopelessness, panic, depression, and PTSD. And there's mass grieving and mass death. And we tended to see abnormal coping mechanisms like substance abuse, violence, protest, hunger, and poverty, disrupting both physical health and mental health systems and services, and therefore calling for palliative psychiatry intervention. And what we saw, which we needed to tell the people that what we needed at that time was crisis intervention, counseling and support services, debriefing to frontline health workers, supporting staff, protecting vulnerable populations, including the disabled, the elderly, pregnant women, the mentally ill, children, refugees, and preparing and equipping mental health clinics and hospitals for disaster mental health care, and then having follow-up plans. Next slide, please. Okay. So what we needed to do, therefore, is to see palliative psychiatry for specific mental disorders. For example, in anxiety, so-called fear of the unknown, hopelessness, loss of control, inconsolable worry, concerns over such matters. Depression, which you saw with persistent low moods, loss of interest in anything, loss of appetite and weight, and having suicidal wishes. And then we saw post-traumatic stress disorder, starting off as acute stress disorder, with symptoms due to witnessing all of these massive deaths and suffering, or hearing about them, and disclosing bad news all the time, with these life-threatening illnesses and death. Then we saw sleep problems, insomnias, disorders of initiating and maintaining sleep, or being too sleepy in the day and having unrefreshed sleep, feeling exhausted all the time. Then we saw people with deliriums, in confusional states, which could either be hyperactive or hypoactive. We saw psychosis appearing in clear consciousness with delusions and hallucinations and thought disorders, and behavioral disturbances. We saw lots of substance abuse, especially of common addictive drugs like alcohol, prescription drugs, and then pain medications. And then drugs like Mairungi, or rather cathinones, marijuana, cocaine, tobacco. And then we saw lots of suicide attempts, and homicides were also seen here. Next slide, please. And then we saw the plight of the people with dementia. I think Paul Chiwanokamuchibi talked about this and what we try to do, meaning showing that here comes a pandemic, but in already a population which is facing dementia or as a terminal illness. And what do you do with those people? We saw what happened, for example, in Europe, in many of the nursing homes. You remember those pictures from Italy, from Britain, from America, you know. Family members and care partners, as well as people living with dementia, had contradicting views of what to do with people who had dementia facing the end of life, and yet with the threatening pandemic, which also threatens the caregivers. And of course, dementia was seen in all of its various stages. The palliative care providers had to care for these patients and families at the same time, who were facing great difficulties at that time. And it called on palliative care workers to really, at their finest moment, see what they could do faced with such dilemmas, fully knowing that these things have happened before in the past, for example, in the plague days in Europe and stuff like that. But knowing that the first line of treatment should really be non-pharmacological. It was what you are going to do non-pharmacologically to assess to assuage the suffering of the many people. And then at the same time, we had to assess for mental competencies of these people with dementia, and also the advance directives, despite all that which was happening. Let's go to the next slide, please. What about these people with severe mental illness, who again we saw being affected by pandemics, you know, serious mental illness like schizophrenia, schizoaffective disorder, bipolar disorder, major depression, epilepsies, severe substance abuse problems, and of course dementia, all of which deteriorated during the pandemics, and the threat to autonomy and to livelihoods, you know, of people. What we saw then was that terminal illnesses or incurable illnesses happening in those with severe mental illness caused a dilemma which needed palliative psychiatry to get involved. Otherwise, they were being neglected, you know, all the time. So what were these end-of-life care issues that were involved into those things? Into those situations, one of which was pain control, relieving discomfort, both psychologically and physically, controlling of irritating symptoms, some of which, you know, were functional, but many of which were physical, and then attending to the psychological issues of both the patient and the caregivers, including anxiety, depression, grieving, fear, loneliness, and then spiritual matters. You know, how were these to be attended to? Fully knowing that during that time, many of the places of worship were actually closed because they were sources of infection. Again, in all of these things, the principles of no heroics and having realistic expectations, you know, were very important. But again, as it came in, including those in severe mental illness, was where are you going to look after them? How are you going to look after them? Where are you going to care for them, given their disruptive tendencies? Let's go to the next slide. Aging and terminal illnesses for palliative care. We have talked a lot about this in all of this, but I think what to me I think is important, and I'm going to summarize this slide, is that chronological age is not an accurate predictor of physical condition or behavior in older people. You can find very old people who are very functional. You find yet younger people, younger old, who are very dysfunctional. Poor health in later life is not inevitable, which means that we can modify how our later life is going to be. Much illness and disability, what we see in older age, is associated with those factors that were modifiable in lifestyles before aging. For example, controlling substance abuse, controlling obesity, treating hypertension, diabetes, making sure you don't have incurable illnesses like HIV. These things become very important as people become older, and they tend to become more ill in the elderly when they're associated with those things. And then, of course, the other factors like genetics and other environmental causes, some of which have been talked about by various speakers. But always remembering that in the elderly, they have mental health needs which must be addressed. Commonly, as you heard, dementia, depression, delirium, psychosis. So what we need to do then when we are faced with these situations, always we have to assess the current mental and physical function of the individual and how this has changed over time in terms of cognition, mood, anxiety, autonomy, frailty, gauging baseline functioning to know what is happening with the passage of time, how they are perceiving things, and how the family also perceives, and how you, the examiner, the therapist, also perceives the situation. All of this comes down to quality of care of people with, say, for example, dementia, which is often tends to be poor. Patients with dementia experience less discomfort in palliative care units, which means that palliative care units must always have room for dementia. They should not only focus, as has been said before, on just the other disorders like cancers and stuff like that, but they should also focus on end-stage dementia, because people feel better there than they feel in usual, nursing care without necessarily paying attention to their specific needs. And also knowing that when we do palliative care management, you have to mention to the relatives, we're not trying to hasten death, but we're trying to come to the reality of what it is and the natural progression of this illness, which begs the question of how do we deal with this behavior and psychological symptoms of dementia, like delusions, hallucinations, agitation, wandering, repetitive movements, aggression, and the verbal problems like yelling, calling out, verbal abusiveness, and then the emotional problems. Some of them become manic or euphoric or depressed. Some of them become apathetic. They may become anxious. They may become irritable. And then there are other disturbances of sleep and appetite. All of these have to be addressed. Next slide, please.
Hi there. We're just running a bit behind. We're wondering if we could wrap up this session in the next couple of minutes.
Yeah.
Yeah.
So patient and caregiving needs must be paid attention to. For example, caregiving and psychosocial interventions. Who is going to give the care? Family or institutions? What kind of care is being given? And why this care is being given? Which I'm not going into details about these people. Knowing that no two people or no two situations are the same in patients that are faced with these dilemmas. We'll not talk about psychiatric emergencies and crises in palliative care, but the important thing to know is that there's psychiatric emergencies there, and also there are crises that come when you're doing palliative care, psychiatric palliative care. Examples of these include suicide ideation or people wanting to die when they're having terminal illness sooner than where the illness is naturally progressing. Crises which usually come due to family disputes or misunderstanding of what health personnel are doing, and also family conflicts in individuals. I think I'm going to end with a slide which, if you can go down, which says psychotherapy and palliative care, because I think that is important. That one. Psychotherapy is a therapeutic process which involves talking about issues and managing them, including thoughts, feelings, and behaviors. and they must involve a trained person, a therapist, not just anybody coming up and saying do this or do that. They must be trained to be able to explore and comfort people, including these negative thoughts and emotions. And especially these become paramount in terminal illnesses and other stressful experiences, especially when faced with life-ending or life-threatening disorders. There are many types of psychotherapies that are given, some of which we must re-examine in African settings to see if they're culturally and contextually applicable in our circumstances. But in most cases, families and couples must be helped, and dignity therapy is important when you're especially dealing with the elderly. In other words, the therapy must be such that they maintain their dignity, so that if death comes, it comes with peace and comfort, and not with anguish and feeling let down. To address issues of meaning, of the life that one has lived, of the legacy that is being left behind, and what they would like to see after their death. I think I'll stop there at this moment in time. Thank you. That's the slide, actually.
Thank you so much.
Our research, but those research areas will come. But I think the only thing that I would like to say about research is that we have to develop and provide cultural adopted psychotherapeutic and interventions that are in keeping with our African values and contexts, because sometimes these things become mixed up. And that is where the research is next, and also how to reach the difficult to access, especially in rural areas. Thank you.
Thank you so much, Professor Musisi, for that presentation. Really appreciate for your contribution today. Yeah. I think we'll be moving on to the next session on grief and bereavement in Africa. But maybe before that, maybe I would ask that maybe we can have a 5-minute break. I think some of us have been sitting, so maybe we start the session at 5 minutes to 7, depending on whichever time you are using.
Okay, thank you. I think just in the sake of time, to make sure we have enough time for our working session, we're going to forego the break. And if people need to step away just for a quick minute to use the bathroom or get a coffee, they can do so.
Okay.
So you think we can just carry on, right? That's what you're suggesting?
Yes, I think that's probably best.
Okay, fine. I'm hoping Dr. Edie Matovu is around. Do we have Edie Matovu?
Yes, I'm around.
Yeah, okay. So you next in terms of giving the presentation. So just briefly, let us welcome Dr. Edie, who is going to present. He is from the African Palliative Care Association. Is going to talk about a community designed approach to increase awareness about grief and bereavement in rural communities. So over to you, Dr. Edie Matovu, please.
Thank you. If you could just allow me project. Is everyone able to see this work?
Yes.
So good evening, colleagues. Good morning to others and good afternoon to some colleagues. This is, I take this opportunity to thank the team that has given us an opportunity to present at this African Symposium for Palliative Care, Social and End of Life. I'm going to be talking to you about grief and bereavement care in Africa. And I think we have about 4 presentations lined up. And my part is to talk about a community co-designed approach or model for increasing awareness about grief and bereavement in rural communities in Uganda. And once again, I'm by name's Dr. Edie Matovu. First, I want to acknowledge the support from Iris Hospice Foundation that has really funded this work that we are implementing as Stove Mobile in partnership with African Palliative Care Association. Fast forward, I'm going to speak to you about a community grief and bereavement intervention model that we've implemented at Chito Mobile for the purposes of increasing community awareness on grief and bereavement services that enhance the support that grieving caregivers receive to improve bereavement outcomes. And the approach we are adopting or piloting in Uganda is integrating a community grief and bereavement services model in palliative care setting to improve outcomes for bereaved caregivers. This model is based on facts and the situation that happens in Uganda, where we observe that caregivers in the rural communities actually face multiple losses as per the situation in most African countries, but actually there is limited support available to them in these communities to help them cope with the process of the emotions and cope with the such losses that would prevent them from going into prolonged grief or acquiring prolonged grief disorders and related depression, depressive conditions. The other fact that we see that we still have high mortality rates and poor health systems. So the presence of these community lay members in our communities is a great opportunity that we can tap into to improve peer bereavement support that involves physical, psychosocial, spiritual, existential issues that we can all be addressed by these caregivers to reduce post-loss psychopathologies that we see in our care settings. In co-designing and delivering this community intervention model, we undertook particular process that I want to take you through. And this is the first one, was to ensure that we identify and form a supportive structure at the community level called a community advisory board. And coming up with this, we were able to hold several debrief sensitization meetings, targeting cultural leaders, community leaders, local government leaders with the purpose of raising their awareness about grief and bereavement, and to ensure that we get their buy-in to support the subsequent community engagements. So we, as this approach helped us to identify and form a community advisory board, and that saw participation of 3 pilot districts that implemented this intervention. This community advisory board held subsequent meetings that increased awareness about grief and bereavement in the communities that were targeted for these pilots, and actually ensured that community responses to bereavement support was strengthened, and that is one of them that we held. The other approach, because we did not have a core team to provide grief and bereavement services and supervise the community intervention model, we started by training palliative care service providers in the palliative care setting of Chito Mobile. And this formed the train of trainers that would be able to cascade the knowledge about grief and bereavement in the lower community systems that we have, where we have the real problem and impacts associated with multiple losses in the communities. So that is one of the trainers, the expert trainers from Zimbabwe, who was delivering or building capacity of the service providers, actually health workers, social workers within a palliative care setting, who actually served as grief and bereavement therapists at Chito Mobile. Let's explore critical topics in understanding what actually grief is and how actually grieving people react to it. The oscillation model that we shall be seeing later on, how people grow around this problem of grief, and what are the helpful and unhelpful support to be provided to the bereaved caregivers. And once we had all these concepts as health workers and social workers at the palliative care setting, we continued to receive mentorship, virtual mentorships from the same trainers, but also from GIPEC, to ensure that we have a critical mass of knowledge and skills in delivering and supervising low-level community structures that actually would otherwise deliver this service in the communities to minimize post grief complications or psychosocial complications. So in, again, co-designing this awareness intervention, we did not begin from scratch. We worked with, we explored through extensive reading and research models that have been applied in the developed world and also in the developing world. And we eventually zeroed at a model that had been previously applied in Zimbabwe that had demonstrated that it increases awareness about grief and women in the communities, that was associated with increased knowledge about morbidities, that it had improved mental health conditions, the social well-being, and positive family relations within the communities where it had been applied to lower grief and bereavement, but also it was associated with the lower scores of grief distress. And the model is basically what I'm as demonstrated in that picture there. It's called the 9-cell model tool. So we worked, and this tool provided a framework for exploring the contextual, individual, cultural, and society issues in Budu region in Uganda that led to bereavement feelings and expectations in our society. As part of the co-designing approach, so we're able to identify community members or community-led grief counselors who would work with the later to deliver the intervention to reduce grief and bereavement. We worked with the community advisory board that I've just mentioned, the community leaders to identify these community members who had actually had a lived experience of the loss, grief, and bereavement. Some of these members were actually community health workers who are supporting other health-related activities within the communities, but also had opinion leaders, cultural and religious leaders who brought together in a meeting to initiate this new model. So eventually, when they were inducted into this approach, we also asked them to identify peers within their social network who they could also train under the supervision of the palliative care providers at the hospice program. So that, and these will also engage in community awareness creation of grief and bereavement. The goal was that these would be able to increase the critical mass of people who can offer grief awareness in the communities. Here is the lower level trainings that were conducted by both the grief experts, but also the trained health workers in the communities to ensure that they expanded knowledge by cascading skills and knowledge about grief and bereavement in the communities, so that we have enough space and enough resource to be able to deliver the community grief and bereavement intervention in the targeted sub-counties or communities where we piloted this program. The community engagement activities that were done as part of this co-designing of this intervention, both the African Palliative Care Association staff, the experts who came from Zimbabwe, and the Kitovu Mobile Hospice team, the local hospice partner, both delivered these programs in the communities to create this critical mass of knowledgeable community providers or community members who had lived the experience of and bereavement, and were able to actually cascade this knowledge and skills to community members who are affected with complicated grief. So this 9-cell model, again, were able to pre-test these tools, again, by using the community-led grief counselors who actually delivered using group storytelling approach in community settings. And the lay grief counselors deliver the grief awareness in the communities as well as creating awareness. These counselors reported positive experiences with the intervention approach that I've just explained, and we are happy to deliver it to other bereaved caregiver or care with other bereaved community members in their areas. So after realizing that, we moved down to the bereaved caregivers that we had on our program. palliative care program at a household level. We were able to assess, when we looked at our palliative care program, we sampled with about 350 families that had had a loss, a death, a most recent death, and were able to apply a screening tool called a bereavement and risk screening tool to identify those caregivers that had complicated grief. And this slide here talks about the caregivers that were able to, the social demographics of the caregivers that were identified with the complicated grief. It is clear that most of these caregivers were actually females, about 67% of them. A number of them had no older education, and most of these were basically elderly and widowed. So these are just some of the few socio-demographic characteristics that I managed to put forward, but a lot more could be shared by my colleagues in the next presentations. So after that, we had to train this community-led grief into data collection because we want to ensure that this treatment and bereavement model, intervention model, can be assessed for effectiveness to ensure that it's able to deliver to what we expected. So we had to train the grief and bereavement community-led grief counselors in the community about the tools that be able, first of all, to deliver the intervention, but also to measure the outcomes of the grief and bereavement services across the number of several visits that we conducted, as my colleagues will be presenting in the next slides. Here, these are some of the community level trainings, the data collection tools to support the documentation for grief and bereavement care services to simulate this area service development. And that was conducted at community level. Fast forward, we had to roll out this grief and bereavement care intervention in the communities. But first, we had to ensure that it's a phased rollout to ensure that as we phase out, we are able to measure the impact of this intervention in the communities and be able to inform the world where this approach really works or really doesn't work. So the intervention was delivered to bereaved caregivers at household level using a phased approach. And each community-led grief counselor was actually assigned to 2 households, to which they had to give the grief and bereavement package, care package, psychosocial psychotherapy care package. And at each visit, there was a different aspect that were of care that was covered. In the first visit, we assessed needs and getting to know the family that was grieved. In the second visit, we assessed the needs of this family, then started providing the grief and bereavement awareness support. And the third visit, we evaluated facts, the myth about grief and bereavement, and were able to address this myth and misconceptions, and so on and so forth. So at each visit, we collected the data on grief and bereavement outcomes. And this is the data that we shall be presenting at a later point in time to demonstrate the impact of this intervention. Here we're actually offering the grief and bereavement care, and this was done by the lay grief counselors who had actually experienced grief and bereavement at a past time, and were now up to other colleagues and members of the community who are experiencing grief and bereavement. So as they help them cope with this loss that they had affected with in the different communities. And in the demonstration here is just a female community grief counselor at Chanamkaka sub-county in one of the districts delivering the grief and bereavement support, and a male community grief counselor who are also offering in another location. We also, remember I've told you about the community awareness advocacy sessions to have a critical mass of the in the community that's aware about grief and bereavement as one of the other interventions that was provided by the community-led members to ensure that the members are able to understand grief and bereavement, discuss it, and we ensure that there's improved community knowledge and reduction in psychometric, psychomeasures, psychopathologies related to grief and bereavement. Again, after the delivery of the services, we measured outcomes for the grief and bereavement services in the communities we targeted. Again, this measurement was done by the community-led grief counselors after receiving the training on tools and how to measure it. And again, like I've just mentioned, we observed wonderful results that will be shared later on. And again, this was done in support or in close supervision by the trained providers from the palliative care support. And this is one of them supporting the community-led grief counselor in measuring the outcomes for the grief and bereavement services that had been provided to these caregivers. Some of the impact stories that we actually seen that have interested us moving forward with the work is one of the testimonies I'm giving here for the caregiver. For example, one of them told us that when I lost my husband 2 years ago, I don't want to see the graveyard. When I would think of it, I end up not sleeping. So this is an aspect of insomnia we captured here. But after achieving this grief and bereavement support, the person or the caregiver was able to cope with given the support that was provided. In the second caregiver, we see one who had lost a daughter of 9 months, and since then I had lost appetite for all the foods and even stopped digging, questioning herself why she had, why her? But when she got the support from the community health therapist, she was able to cope and resumed work and normal nutritional feeding, and eventually able to return to normal activities, including visiting church. The third caregiver example that we typically pull out here was a mother who had, when a caregiver had lost a mother who had died 3 years ago, and this had made us stop normal cues, including praying, and was grieving terribly. So until she got the support, that was the lifesaver for her to regain her normal circumstances. So with that brief, I want to still thank so much Aerospace Plus Foundation that has funded this work. And again, African Palliative Care Association for continuously supporting and providing the technical knowledge to both the palliative care, the hospice and palliative care team members, but also the community lay members to continue advancing this work. I want to thank the community-led grief counselors in the region where we piloted this program, the community advisory board, the implementation team that comprises nurses, Jackie, David Mwonge, Namugenyi Florence, and the Center for Advancement of Bereavement Care at Sylvester Comprehensive Cancer Center, University of Miami. Thank you so much for listening to me, and look forward to answer any questions that may exist. Thank you.
Thank you so much for that presentation. We are moving on to the next presentation, which is going to be a recorded presentation by Dr. Wende Lonchentel and Dr. Eve Namisango. Briefly, Dr. Wende is the director at the Center for Advancement of Bereavement Care, that is in Miami. And the talk is going to focus on future developments, Ugandan community co-designed intervention for grief and bereavement, and the application of tools. And as I said, it's also going to be presented by Dr. Eve Namisango, who is already known to us. She's the research and programs manager at the African Palliative Care Association. So let's listen to the recording, please. Thank you.
Hello, everyone. My name is Wendy Lichtenthal, and I am honored to be able to present to you next steps for grief support in rural communities in Uganda, through which we are developing an evidence-informed bereavement care protocol. I am so pleased to be collaborating on this project with my colleagues Maddie Rogers, Dr. Kaylee Roberts, and Dr. Eve Namasengo from the African Palliative Care Association, who really spearheaded this initiative. This initiative really is going to build upon the work that Dr. Matovu just presented. And so I'll start with just reorienting us to that work where community lay grief counselors were trained in the 9-cell bereavement care approach. And this approach was compared to community lay grief counselors delivering Ubuntu, the traditional approach, in families' homes. And what it suggested was for bereaved caregivers, peer support in the home was both feasible and acceptable. But what this work also suggested was that there are ways that this approach could be improved and strengthened through perhaps a more standardized protocol. And that is what has led to our current initiative, where we are developing an evidence-informed bereavement care protocol for both the palliative care team and community lay grief counselors. Now, this work is built upon the transitional bereavement care model, which promotes continuity of care from end of life through bereavement, and where we see a shift in emphasis over time, similar to the kind of classic palliative care model where there's a shift in emphasis over time. After a patient's death, there's a shift in emphasis from the healthcare team's support or hospital-based support as there's a shift to community-based support. And so we're really promoting this idea where the institution or the hospital or the palliative care team, that healthcare team, remains in contact to some extent with the family to not abandon them. But also we understand that resources are finite, and ultimately the family is going to be supported by their community anyway. And so while we want to provide resources and support for the healthcare professionals to support the families, we also want to bolster up the capacity for the community to support families. The work that we're doing is also built upon the public health model of bereavement care, which puts forth this idea that while everyone could use some form of support after the loss of someone significant, not everybody needs professional support. So you'll see here on this pyramid that was put forth by the Irish Hospice Foundation that there are different levels of need and levels of care, level 1, 2, 3, and 4. And so we can think about the fact that as the needs of a given individual increase, their level of care and what might be most helpful to them would increase as well. At the bottom of the pyramid is everybody. Again, everybody could use, for example, compassion or acknowledgement of the loss. But individuals who have increased need might benefit from peer support or for individual counseling, or at the top of the pyramid for individuals who are maybe struggling the most with mental health challenges, they could use specialized professional support. So if we're going to be talking about this idea of different individuals needing different levels of care, it's important to be able to identify these individuals. And for that, we've been conducting work for the past several years on developing a self-report bereavement risk assessment. And this has led to the development of the BRISC, which is the Bereavement Risk Inventory and Screening Questionnaire. The items in the BRISC were developed based on the literature on predictors of poor bereavement outcomes like depression, prolonged grief, post-traumatic stress disorder. And a measure with 34 items was ultimately developed, tapping into different domains of risk factor, including background factors about the bereaved individual. So that might include their mental health history, a history of suicidality or trauma. It also covers aspects of the relationship that might be predictors of poor outcomes, such as conflict with the deceased individual or dependence on the deceased individual. And then it covers factors that are related to the circumstances of death, such as experiencing death as traumatic or feeling unprepared for the death. What we did in collaboration with our colleagues was give this screening measure in its totality, all 34 items, and have it be part of the trial that you just learned about from Dr. Matovu. And it was delivered to those 120 bereaved caregivers in Ugandan rural communities. And what we were looking for is, in this community, what would be the strongest correlates of a high score on the BRISC. This way we can winnow down the measure, have something that is briefer, more clinically useful perhaps. And you'll see in bold, these were the items, in black bold, the items that were most strongly correlated with the total score. In red, you see items that we thought were clinically important to add, such as social support or past suicidality. And ultimately, this led to development of an abbreviated version of the BRISC that has been adapted for the Ugandan rural communities. The BRISC, as it was delivered in the previous trial, was delivered in person in the local language. This 14-item BRISC will be delivered similarly, and it includes 11 items that are in black bold that were most strongly correlated with that total score, as I mentioned: mental health history, trauma history, difficulties with sense making, financial problems, for example, and those additional items of social support quality and past suicidality, and ultimately adding an assessment item to assess the relationship to the deceased. So this would be the kinship type. Is this a bereaved spouse? Is it a bereaved parent? And so this 14-item BRISC can be used to then best identify the individual's level of need. And this brings us to the bereavement support protocol that we've been co-designing with the palliative care team, with the community lay grief counselors, and our team, to really take interventions that we've conducted in the past that have an evidence base and create something that is concise and digestible and deliverable for the community lay grief counselors. So the entire protocol includes a pre-loss visit by the palliative care team, a bereavement call, and then 4 visits from the community lay grief counselors. In our protocol, there are guides and exercises as well as guidance for the providers themselves. So I just want to give a high-level view of what this protocol looks like. The pre-loss visit that I mentioned that will be delivered by the palliative care team really is going to be in part an orientation to see where this family is at, what is their understanding of the patient's prognosis, discussing goals of care, and assessing their needs. What level of need does this family appear at? In that pre-loss visit, communication with the patient might be facilitated, and really importantly, the team would be communicating their continued presence and support of the family. Now, this would be followed after the patient's death with a bereavement call by that palliative care team. And in that call, of course, condolences would be expressed. But again, there would be this assessment of need, a referral to resources if that seems indicated. These could be practical resources like financial resources, or it could be emotional support resources as well. An inquiry about burial plans, memorials, if appropriate. And then very importantly, the real key to this work is that there's going to be this transition to the community grief, the community lay grief counselor. So in this call, a visit with the community lay grief counselor would be scheduled, that visit 1. And the transition then to community support would be made. This, the set of visits I'll just give an overview with would be conducted by these community grief lay counselors. And in that first visit, of course, there would be an expression of condolences by the lay grief counselor, a connection with the family about the patient. But again, very core to each of these visits is an element of assessment of level of need, what sources of distress there are, and really empathic support. So much of what acutely grieving individuals need is that validation and support for what they're feeling. And so that will be a part of each of the visits. And then in that first visit, the lay grief counselor will also review some tools to cope with intense distress. And these were culled from another intervention that we've been working on with caregivers of critically ill patients, where we bring in exercises like breathing and grounding and mindfulness meditation. So really to equip the griever with additional tools while they're promoting the idea of giving themselves permission to grieve, also empowering them with some tools in their toolbox. A referral to resources would be given if indicated, and then a follow-up visit number 2 would be scheduled. In that next visit, the same model would occur: an assessment of need, validation and normalization of challenges and concerns, a review of those tools and their applicability for a given grieving family member. And then in visit 2, more psychoeducation about grief and bereavement would be provided. Each visit, the referral to resources, if indicated, would be provided, and the next visit would be scheduled. Visit 3, same idea: an assessment of need, validation, review of those tools. In this visit, psychoeducation would focus more on connecting with the deceased. How do they remember them? How could they connect with them? Understanding the push and pull that many grieving individuals face because of the acuteness of their pain. Any adaptive coping strategies that the lay grief counselor is witnessing would be reinforced and highlighted. Referrals to any necessary resources would be provided, and that 4th and final visit would be scheduled. That 4th visit, again, would follow the same model of assessment and support, but in this visit, how the individual might cope with anticipated stressors in the future would be discussed, and any referrals to additional resources based on a grieving family member's level of need would be presented, normalizing the need for additional supports for anyone who indeed does need that. The lay grief counselor would express the appreciation for their time spent with the family and ultimately make that referral for any family member who might need follow-up care from a psychologist or a psychiatrist, for example. So in sum, we are seeing that the extension of bereavement care through community lay grief counselors can play a critical role in supporting rural communities in Uganda. And the protocol that we're building is based on that traditional bereavement care model and a public health model, so that we can really tailor support to the griever's level of need, building in bereavement risk assessment and taking tools that have been from other evidence-based approaches and building them into a protocol at a level the lay grief counselor can deliver. Our next steps are to now train the community lay grief counselors in this approach. We specifically will be focusing on the cadre of grief counselors who delivered the Ubuntu intervention, that was the control arm in the previous trial, and train them in that 4-visit protocol, as well as training the palliative care team in that pre-loss visit and bereavement call protocol. And then to conduct a pilot trial evaluating this new approach. We are still trying to determine the best control arm to use, but what we do know is that we will be including additional outcomes that the lay grief counselors really deemed as important based on their interactions with bereaved families and build that into our next trial. So I want to thank you for your time and attention. Please feel free to reach out to me with any questions. And I want to thank Sylvester Comprehensive Cancer Center, our grant funding, and our colleagues Jesse Schlichting and Hannah Candela for their contributions to this presentation. Thank you so much.
Okay, thank you. So let's have our next speaker. So Ms. Lutizo Kwonge, who is the social worker at Island Hospice in Zimbabwe. So she's going to talk about grief and bereavement mode of care in Zimbabwe. Thank you. Over to you.
Hey, greetings everyone. Nkoma, are you sharing from there or should I try and share from this side?
Did you I'm not sure if did you provide your slides? I can ask my
Okay,
colleague.
let me share from here.
Okay, please. Yes, we can see the slides. Can you just put it in the presenter's mode? Presentation mode, please.
Do that just now. Greetings, everyone. I was going to put my video. Is it on? I wanted to show it and then switch it off. Anyway, I am greeting you from Zimbabwe, and thank you so much to the presenters, Dr. Edie Matovu and Sekane. They have already touched on some of the things I was going to present on, but I will continue. And maybe also thank you to the other presenters. Everything is so relevant to the work that we do. I'm a clinical social worker who's been with Island Hospice for a long time, and I also supervise social workers within the organization. As most of sub-Saharan or African or low middle class countries, that is the situation of Zimbabwe in grief. It faces a lot, significant mortality burden because of high suicide rates, natural disasters, cancer, chronic illnesses, and we've had recently, you read in the media, a lot of suicides within Zimbabwe. It has also have social impact of in grief in Zimbabwe. You'll find that because of so many deaths, it has impacted the families. You'll find that there's so many orphaned children, widows, which is actually making them so vulnerable as families. And on economic challenges, which is obvious, most people will read about it. There's so much poverty, unemployment, loss of income, which further complicates the grieving process, adding economic stress to the families. We also have traditional practices that impact on grief. You'll find that there's so many rituals as people go through the grieving process. And the family and community are involved in Zimbabwe. If you have a funeral in Zimbabwe, you'll have your neighbors, your family contributing to the funeral and everything else that happens around the funeral. There's a lot of emotional support. And then the expression of grief, you'll find that when in Zimbabwe, in some parts of Zimbabwe, especially rural areas, there's an expectation for people to show restraint in the way they grieve, not to display in public, except maybe on the funeral day, where they can wail and even do a bit of other drama around it, But after, if you have a complicated grief, it's difficult for you to just cry in public. There's a certain restraint to it. And then resilience and strength in grief. Grief is acknowledged, but those who are strong sometimes are taken as they're highly valued. And in some communities, there's even pressure to return to normal life quickly, which can impact the grieving process. I will give a bit. The next slide is a bit about Island Hospice. So, all right. Island Hospice and Healthcare was established in 1979 as the first hospice in Africa. It pioneered It pioneered the development of expert palliative care services, including bereavement services for families and the communities. Pilot from its beginning until the present has played a major role in scaling up palliative care, research, training, and bereavement service in Zimbabwe and regionally. As Island Hospice will also provide psychosocial support, debrief session to individuals, corporates, civil society organizations who go through trauma, even of death of staff members, changes in organizational culture. We give presentations on various issues such as mental health awareness, sickness, and loss of a family member, dealing with stress and other health and wellness issues. Now we are putting up our models for you to see. One-on-one bereavement counseling is done by our registered clinical social workers, and it's also done by our caregivers in the community. I'm going to give a brief on this, which I've just put in summary. The 9-cell bereavement tool in the communities, which I will just brush through because it has already been covered. Then we have bereaved children's groups that we do, bereaved adult therapy groups. We have debrief sessions, as I said, for disaster accident survivors. The 9-cell, which I'm rushing through, is a tool, obviously, that has been mentioned already by an independent consultant who was for quite some time part of Island Hospice. She still is. I won't go through this. Its aims have been mentioned. It raises awareness, and it explores the support, everything, checks out what approaches are helpful within a community. No, I'm not going. Where do we use it? As we said, it's an awareness for communities in churches, leaders, residents, organizations. Training, we have an integration program where we train within in Zimbabwe hospitals, where we train health professionals. We use it as an awareness tool to just start off and to get them to awaken to the need of learning how to deal with grief and bereavement in a whole community. We also use it in caregiver module training. We do module trainings where we have people that apply and come in for training within Island Hospice. Then we use it there just as an awareness also. That's the tool that was presented, and I think I had put how it works, but I won't go into detail, but really it's filled in by different groups of if it covers huge groups. So if you put 3 groups, it's best downwards, where one group has 3 flip charts. It can write what they experience, what they go through immediately after a bereavement or death in a family. And what is shown, what others who go to a funeral see, and then what is allowed, what is expected. It's also another angle that they fill in the first group with 3 flip charts. Then the other group fills the other 3 flip charts of what happens after several months and then after a year. That's the description I was putting there. After the group work, this is what happens. There's a meeting where the facilitator discusses and compares what has been put up in the different 9 cells and notices how rapidly feelings are hit, and they compare the felt and the shown, the expected and the felt. That awakens when you look at the columns. Each time when you are doing when you're using this tool, you'll find people surprised at how they can feel a flip chart themselves on how they feel, and then on how the society expects them to be, especially after a year or especially even mid-year after the death. It always conflicts, and that awakens them. And then the overall is to add knowledge after group work, there's also a home visit where a trained therapist, a trained counselor will go and model, even managing to ask a question to a bereaved person, a question that maybe a volunteer was avoiding, and then the client breaks down, and then the therapist can continue. Afterwards, when we return to the bigger group, we always ask the volunteer how they felt, and we even eventually ask them to go and ask the very person, the patient, how they felt with the session which was done by the therapist. It's just modeling. So it's a tool. We introduce also concepts when we're summarizing the different concepts of grief. As I said, it's sharing knowledge, normalizing grief. I'm now trying to rush through it because it has been presented, and information giving on specific the areas of discomfort like suicide, children's stigma. Then we go to the benefits when we've already, you can even hear as people present that there's so many benefits. I think one of the ones that I would want to highlight is that it closely resembles theory and literature, but drawn entirely from personal experience. Do you know, sometimes like the Elizabeth Kubler-Ross, the stages, which we know that everyone grieves their own way. It's not in stages, it can be stages, it can be different theories. But then when the people have put the charts up, sometimes they see, when you now summarize with the theories, they can see some of those theories being reflected through their own flip charts, through their own experiences. And then there are other benefits. The accompanying of visits with the community volunteer also helps for them. And it's set in a community. You know, you do it with the very people who live in that community, and they can remain in it, utilizing the tool. This is some of the qualitative results that come. I now have an appreciation of what not to say, not to judge people, not to stand by not to stand. They've learned to stand by someone who is grieving and not to avoid them. I've gained more experience. I've learned to choose the right words in comforting others and not to judge. Now, moving to the other area, another model of bereavement care we do through Island Hospice. We work with children, and we do grief work groups, holidays, and even when it's not holidays, but mainly during the holidays for the bereaved children of our patients, bereaved children in the community. Normally, it's 3 facilitators, 5 years, 18-year-olds sit in the group. That's a sample program where when you introduce, you normalize crying, you talk about confidentiality, they get to know each other through a trust game. There's a break, they draw their families. This is what's the most interesting part. Sometimes they include or exclude the person that has died. And then you ask them to share with the rest, their family, drawing. Then that is when they start learning to share what happened. The other members will be asking, tell us more, because you inform them that they can ask each other any questions. Then there's an educational input that comes, which covers child-friendly information, because every child really, whether bereaved or not well, or in a home where there is bereavement, they need information. They need to express their feelings. So we go and give information in these groups with specific charts anyway that are emphasizing cancer, if any. Then the child goes to where they think they fit, accident, suicide. They work the children with a facilitator. And particular issues are discussed in depth. There's lunch, and then it continues in the afternoon. There's letter writing, there's coloring of feelings, letter writing to the deceased. Then they do what they want with the letter. It's either some of them will say, no, you can keep it, or some will decorate beautifully, say, I'll keep it. Some will just tear it and leave it within the session. Then we sometimes end with family rules to check how this is called how they live at home. Are they allowed to cry? How do they express feelings? This we do so that if there's a problem, sometimes after the follow-up group meeting, we go to the family and bring in a way of helping the child to communicate through their grief. The benefits, sharing a common problem helps the children to normalize. You'll find that when they're sharing their problem, they normalize their grief. It helps them a lot. It's easy for them. They feel less alone and they feel less different from others. And when children are taken seriously by the facilitators and others in the group, they feel safe to talk about their problems. And hearing other children's experiences can make the children feel less guilty, responsible, confused, embarrassed, or ashamed for what has happened to them. And then information and education in a group helps the children understand that what they are feeling is normal. The questions and answers from different members are helpful, especially for children who are too shy to ask many questions. We also have other the measurement for children's groups. Sometimes parents, when they come in, they are nervous when they drop children. They are not sure whether they'll make the children cry again, but they always feel when they pick the children are so they show they know they're bouncy, elated, satisfied children. And the follow-up session, post-group sessions have proven that also there's a spin-over even of family members starting to talk about it. The other bereavement groups that we do, we work with that. These are groups now. If people have lost their workmate through accidents, loss of a child, there's a group, spouse, all these are groups that we do, and we train others to also do the different groups. In those sessions, what normally happens is even the letter writing is done as a group. What I miss most, things like those when people are together, memories. There's someone who also related something to do with memories in the presenter's past. All these anger, fear, loneliness is also looked at. Am I going crazy? They can always share in a group, and this needs a trained facilitator who will know how to handle and how to get everyone talking and moderating in their sessions. There's one-on-one bereavement. This one, we use theories. The Bowlby, Elizabeth Kubler-Ross, Strub, and Stewart, Tonkin, Wood, and we use all those theories when we do our one-on-ones. But we make it culturally relevant when it's Zimbabweans. But when we have the other culture that also comes in, the Western theories also are utilized. We have learned to find a way in which we work through for the healing journey of a particular client. We do a lot of this. We see men of recent, most men who have lost jobs, lost money, they are the ones who normally are coming mostly. They losing status and failing to cope, triggering past losses. Widows, children, a lot of children come when their parents are divorcing or they themselves have lost a sibling or parent. All that we varied. The challenge is replicating the models in a wider coverage. I was very interested when I heard the Uganda team talking about how they've covered a wide range, rollout. And I was wondering, where are they getting these resources? But anyway, it's okay. The challenge is trained personnel, as I said, even to do groups, needs facilitation skills and certain knowledge of bereavement and grief. And we face inadequate resources, which is most of our countries. And then sometimes there's a cultural barrier, mental illness, and grief. When you are having complicated grief, people, you think you are also, they say you met an ill, and it's all goes.
Hi, Latizo. Sorry, can I interrupt? Do you want to wind up, please?
Yes, I'm winding up now. Thank you. So our opportunities, thank you so much. Our opportunities, we can integrate like with palliative care. It's already, you can read all that. We can train health workers, we can leverage our community and religious churches. What else? This was spoken of policy changes, increasing funding, public awareness. Those are some of the reference. Okay, sample activities, letter writing, comfort items for children, counseling rooms, children in session, caring for self, activities we do, what I experienced since your death. These are the last slides, feelings in my body, and then my late cousin drawing. And then that's it. Thank you for allowing us to be part of this symposium and presenting. Thank you so much.
Thank you so much for that presentation and information more about what happens at Island Hospices. Yeah. So I'm now going to invite the next presenter. Sorry, let me get the... Okay, so the next presenter is Mr. Saif Muhammad, who is at the World Health Organization Collaborating Center in India. He's associated with the Kerala Palliative Care Organization in India. So over to you, please.
Thank you. Thank you for the opportunity. I know that we are very behind the schedule, so I'll make it really quick. Not more than 10, 12 minutes. What I'm planning to do is to give you an overview of the program that we do in Kerala, in India, at Institute of Palliative Medicine. So I have got a few slides. I'll quickly pull up the slides. I hope this is visible. Can you see my slides? Are we able to see my?
Can see them. Yes. Can see them.
Yes.
Yeah. Thank you. Thank you so much. So we have named this program Bereavement Companionship Program, and this is now being implemented as a continuous program as a joint initiative of Institute of Palliative Medicine, which is a WHO collaborating center in India, and the first collaborating center for palliative care in low and middle income countries. I think that some of you might have read about the Kerala model of palliative care. And this is the institute which spearheaded the model. And this is the first ever palliative care institute of Kerala. And this program is jointly organized by Institute of Palliative Medicine and as well as the Dutch Literacy Institute of Australia. I'll give you an overview and what we do in the program. So just to give you an oversight that we all know that grief shatters our personal identity. So what we are or who we are is created through the personal stories that we create with people in our close circle. So we are nothing but our memories, our stories that we create, the narratives that we create. And when someone dies, what happens is that these narratives are shattered. The stories are affected. So the person is no more there. So we tend to keep asking that, who am I without this person? What am I going to do with the stories that I have already created? And what am I going to do with all those things that I had planned with this person who was a very integral element of my life? So this, I think, is an important thing that we have to keep in mind while we create the models and programs for supporting people in grief. And I believe that, the people who have created the program believe that supporting someone in grief is an essential life skill. This is not a luxury. This is a societal standard that we have to follow. And like any other life skill, this is a skill that all people should possess. So we are not, limiting this program to healthcare professionals. We do this as a continuous skill building workshop in our institute, both online and offline, so that as many people become aware and get trained in how to support someone in grief in their close circle. So there is an interesting story behind the origin of this bereavement companionship program. Like most of you must be knowing, Kerala is well known for palliative care. We started palliative care around 30 years ago. And from the beginning of the palliative care, we had decided that we will keep palliative care as a social program, not as a medical program. So with that insight in mind, the beginners of the palliative care program in Kerala were able to develop community-owned programs in every nook and corner of the state. And we also have a palliative care policy. And because of that, there is a palliative care program running in every village under the leadership of the government. The primary palliative care program is universal in Kerala, and there are around 700 community organizations doing palliative care in various pockets. So Kerala is well known for palliative care. And the thing was that the limitation of the program was that bereavement was not taken seriously. Even though we talk about bereavement in a very important way in a graphical representation of palliative care, this was not taken very seriously. And then we were forced to take bereavement very seriously during the time of the COVID. So in our institute, what we did was during the COVID period, we had set up an helpline of doctors, not for palliative care patients alone, because entire state of Kerala was in lockdown. So there were people who were supposed to meet or consult doctors for their regular treatment, for their curative treatments, like major health issues. But they were not able to go out of their house. So this was becoming a huge health problem in Kerala. So at Institute of Palliative Medicine, with the help of our volunteer, we set up a helpline number of doctors. There were around 100 doctors who supported this from various specialities. So the program is like this, like whenever who needed doctor's consultation, they will call up this helpline number, and then we will talk with the concerned specialist doctor, and then we will connect this patient with the doctor. And once the doctor suggests medicine to the patient, that will be shared with us. And we make sure that that medicine is delivered at their doorstep, wherever they are from Kerala. And this was done through the police network. So this was a collaborative of police and Institute of Palliative Medicine. And this was going well. And then came the second wave of COVID. And like in many other parts of the world, the number of deaths were very high in Kerala during the second wave of COVID. So the calls that we were receiving at Institute of Palliative Medicine, the helpline, was a lot of panic calls asking for support because their loved ones have passed away and they were not able to do their rituals. What usually happens is that during the second wave of the COVID, someone with serious health issues will be taken to the hospital, and when that person die in the hospital out of COVID or some any other reasons, the burial, everything will be done by the hospital using the protocol. So the family members, they are not able to get a closure. They are not able to know what has happened to that person. That rituals and other things help us to get a closure and make sure that we are giving a goodbye to the person. But this was not happening during the COVID time. So we were getting a lot of panic calls. So we were like, what's happening? Because we had thought that Kerala is a close-knit community and a state with a lot of palliative care program, these things like grief and bereavement are automatically taken care of. But we were wrong. So then what we did was we did a focus group discussion with people who have lost their loved ones during COVID as well as before COVID. So this focus group discussion focused on the challenges of grief and bereavement. And to our surprise, all of them told us that the people who attended the focus group discussion told us that the emotions or the thoughts or the emotional pain that they go through is not at all addressed. So in Kerala, when death happens, there will be around thousands of people visiting this house. The cooking will be done in the next house. Childcare will be provided by the neighbors. Friends will be there. But then we could know from the focus group discussion that whatever help people are giving is good and important, but that's only very peripheral. Even during COVID or even before that, supporting people in grief was not happening in a scientific manner, and also their emotional pain was not addressed at all. So then we had a discussion with the Distillery Institute and other institutions, and then we developed this program. So one thing that we could realize is that having the skill for supporting someone in grief is a life skill. So we looked upon it as a community, skill building program, not for health workers or only for, secluded groups, but not only for few people, but this was open to all. This is an open for all program, which is continuously happening in the institute every month. And we also do it online. So this is designed to equip the community members to provide compassionate and emotional support to the bereaved in their close circles. It's not that once you go through the workshop, you'll be able to, designate yourself as a bereavement counselor. No, this is not about building bereavement counselors or bereavement professionals. This is about building bereavement companions. If someone is undergoing grief in your close circle, in your workplace, in your school, in your college, in your neighborhood, in your family, someone should be there who is equipped with the knowledge and skills to provide informed companionship. This is the whole idea of the program. And mostly what we focus on a compassionate presence within the immediate social circle. So not grief therapy or counseling, but skill companionship. And then we develop them with necessary knowledge and skills so that they are compassionate listeners. They know how to talk to that person. They know how to explore the emotions. They know how to ask the right questions. They know what to do and what not to do. Very importantly, what not to do and what not to say when someone is grieving. So this is the overall picture of the program. Basically, these are the things that we cover. Understanding the basic concepts of bereavement itself. What do you mean by loss? What do you mean by grief? What is bereavement? What is anticipatory grief? Things like this. So basic knowledge building. Then how can you be a informed companion? How can you be a skilled companion? So that is covered in companionship. And most importantly, communication, listening, also exploring the emotions, validating the emotions. So these are the things that we cover in communication, and also identifying the people with high risk grief. So it's not that it's not about equipping them to address high risk grief, but identifying them. So what could be some of the symptoms and what you are supposed to do as a companion if you notice someone is going through a complicated or pathological grief. And a lot of the things are about self-knowledge, because we think that if you are someone who is trying to understand the other person, the emotions and thoughts of the other person, first you should have a knowledge about yourself. So a lot of the sessions are very reflective. We have named it Knowing Oneself. And because we believe that it is imperative that you know yourself best so that you can understand others. You know what are your strengths, you know what are your challenges, and you best use of your strength, and you manage your challenges when you deal with a person. So this is the overall component of the program. So these are the components: understanding grief and concepts and models. And when we talk about models, like the other speakers have said, we explore the Western models, we take lessons from that, but we adapt it to the cultural nuances of our setting. Effective companionship. And also one other part is addressing grief in children and emphasizing self-care for the companions. What we are intending to do is that if death happens in one house, there will be anyway people visiting there. So our dream is that at least one person in 50 people visiting there should be skilled enough to provide a scientific companionship to that person. So these are some snapshots from the program. This is how we publicize the program. This is now a monthly 2-day workshop in our institute, and we also do online. We have done it for Bangladesh, Thailand, Philippines, and it's all very activity oriented, like you can see in the screen. So that's all from my part. What we have seen is that this is seemed to be very effective, and I was called to present the model in the Public Health Palliative Care conference that happened recently in Bern. And all of the participants, we have an ongoing feedback mechanism built into the program. So wherever people join the program, even if they're from Africa, if they're from Philippines, if they're from Thailand, if they're from Kerala, if they're from India, if they're from Australia, from wherever they join, they do an assessment or a feedback of the course using a QR code. And what we have seen is that most of them, almost 98% of them, have reported that this was highly helpful, and they, or were like, some of them were saying that they were quite late to do this, and some of the things that they have done while supporting someone in grief was wrong. So now they have learned how to do it scientifically, and then we have seen that people are using this skill to provide good companionship to people in grief. So that's all from me. So if at all there is something that you want to ask or comment, I'll be happy to do that. And then I think we can also use the chat box. Thank you.
Thank you so much for that presentation. Yeah, I need to be guided by colleagues in terms of what are the next steps. Okay, so the next step, we are going to have a session on end-of-life advanced care planning. So I think here I have to hand over to Eve and the team. Thank you.
Hi, everybody. Is Breffney on the call?
I am. Hey, Leslie.
Hi, Breffney. Just due to time, we're going to show, we're going to have the presentation from Dr. Heller, and then we will make Craig Sinclair's video available to everybody to see it after the presentation, after the symposium.
Thanks, Leslie. Hi, everyone. So pleased to be here for what's been an incredible meeting, and thanks to all the great speakers. We are running behind time, which is a testament to how engaged everyone's been and all the incredible presenters and topics that we've heard. So let's try and get back on track a little bit over the next 20 minutes. I'm pleased to introduce our first speaker, who is Dr. Lane Heller. Dr. Heller is a palliative care specialist who moved from the United States to Mozambique 15 years ago. What an adventure, where she founded Casa Ahava with her husband, which is the country's first convalescent and hospice home for cancer patients. It's been operating now for nearly 13 years and has grown to a 17-bed capacity. What's really unique about this hospice is that it's connected to Lane's family home, which provides her with unique insights into the lives of cancer patients. And I think this is a pre-recorded session, so hopefully we get to learn more about Dr. Heller's work.
Hello. Good to be here with you guys tonight. As you heard from my bio, I have lived in Mozambique for the past 15 years of my life, but I would like to give a little disclaimer. I am American and I'm speaking to an African audience about your own culture. And so I pray that you would receive this with all the grace, knowing that I am a learner on this continent and I am learning from research, I'm learning from experience, and then I'm taking that and I'm hoping to be able to improve palliative care here in Mozambique. So there's my disclaimer. I would like to talk to you guys a little bit about the work that I'm doing. I'm super passionate, super excited about what we're doing here in Mozambique. My presentation tonight will be about preferences matter in palliative care. So to give you a little bit of a background, just so you know, palliative care in Mozambique, from a national level, we do have policies, manuals, and curriculum. However, those have not yet been integrated into the healthcare system or implemented in any real fashion. We do have one standalone palliative care unit. It's located at the Government Central Hospital. It does some beautiful work with a focus on cancer patients, primarily pain management. However, they do offer consults for psychology and social needs. So they're doing a beautiful job. However, it's a small enough unit that it's really not meeting the vast need that we have. One massive issue that we have limiting palliative care in the country is that we have inconsistent access to morphine, even here in the capital city. And if you're from the provinces, that is even worse. Okay, so when we're thinking about palliative care, we know that palliative care is based around the patient trying to decide how we can improve their quality of life with serious illness or at the end of life. So I want you tonight to imagine with me that you are a cancer patient in Maputo. And we are going to imagine that 1 week, your one treatment week that comes every 3 weeks or so. So for a typical person, because of where they live, in order to afford the cost of living, they live quite far out of the city. So they need to wake up around 3 or 4 in the morning, and they're going to start their day, take a bath, get ready. Then they're going to need to walk to a public transport stop. There they will wait, often in a line, sometimes needing to push their way onto their first minibus. And from there, they're going to have to get off and on and off and on, oftentimes multiple minibuses, every time having to wait in a line, every time having to push their way on. They'll finally get to the hospital maybe 6:30 or 7 in the morning, where they will sit in a hard chair or on a hard bench and wait for their name to be called for their blood draw for the month. After that, if we're lucky, we're looking at like 10 in the morning, they begin their journey back to the public transport stop to take multiple minibuses home. That's the first day of treatment week. From there, the very next day, they're going to repeat that whole process, but this time to wait for the specialist, because the ratio of specialists to patients is quite abysmal. They're going to have to wait even longer and maybe start that journey home a little later in the afternoon. If their blood work was good, they'll repeat the next day, maybe for an ambulatory treatment of chemotherapy, and then they will return home even later on the third day, or perhaps they'll need a transfusion. If they need a transfusion of sort, they'll repeat the next day and then come the next day for chemotherapy, or if they're going to be admitted, they'll come back the next day to be admitted. So we can see that treatment and consults are quite burdensome on our patients. We're thinking about this situation, right? And so we need to develop culturally appropriate African palliative care models. Our patients are not the same as patients in America. They're not the same as patients in Europe. So we need to think about what is the available funding that we have and what are ongoing costs. I've seen so many beautiful projects start, and then within a few years, they're gone because ongoing costs were not able to keep up with it. Medications available. I already talked to you about the fact that we don't have morphine often. So what do we do in lieu of that? What can we do? Are there traditional medicines that we can use to kind of help our patients feel better? How many trained professionals do we have? What can we do with what we have? Also, as Africans, spiritual beliefs are very important. We cannot forget them. So here we are, we're starting, what do we actually know? Okay, we know that palliative care is based on the preferences of the patient, the person, and their family in order to create goals of care that are going to improve the quality of life of the patient. However, we know from beautiful research done. There's so much research done about personhood in Africa and how it compares and how it differs from personhood in the West. One of the main areas here that is different is the communal aspect of things. When we're looking at the patient sitting in front of us at the doctor's appointment, we need to take into consideration the decisions that we're making around their family, around their community. The next point goes right along with that the value of autonomy is not the same in Africa as it is in the West. Sometimes what's best for the patient isn't best for the family or isn't best for the community. And how do we make those decisions? And what things do we prioritize? Illness understanding. Again, there's beautiful research done about this, that illness understanding is not the same in Africa. It does include it includes bacteria and viruses and things and parasites. However, it also includes curses. It includes ancestors. It includes all sorts of other things. So when we're thinking about illness and health and how we're going to make our patient feel heard and seen and cared for, we have to include all of this. We are also primarily dealing with a paternalistic doctor-patient relationship. And I want to talk a little bit more about this because I've actually done some research and recently published a paper in the Journal of Palliative Medicine about this. I feel like paternalism gets a really bad rap. So paternalism is when the doctor decides what's best for the patient with little to no input from the patient, and then they say, okay, this intervention is going to happen, and they encourage the patient to consent. This is versus a shared decision making where the doctor kind of lays out treatment options. They get some ideas from the patient, how they feel, then the doctor might offer a recommendation, but in the end, the two decide together. In my paper, I explain more. There are actually some causes that contribute to an actual need for paternalism in the society that we're in right now. Number one, language. In Mozambique, if you think about it, there are over 40 languages. So oftentimes when you're in a doctor consult, the patient is not speaking in their first or second language, and they might not be understanding completely what's happening. Education. Almost 40% of the population of Mozambique is illiterate. So we are talking, in order to make an autonomous decision, to be able to understand the treatment options, to be able to understand your sickness well enough to be able to decide what intervention should happen, oftentimes it's just not the case. Culture, there are power dynamics at play. Oftentimes in the medical consult, the patient is not going to feel open enough to share their preferences and priorities. Also, perception of the provider. They kind of expect the provider to know more than them. And so if the provider starts asking them things, they can think, oh, does this guy not know what he's talking about? Also, time constraints. Mozambique has 3 doctors and 21 nurses per 100,000 people. So the time of our consults is very small. It is not the place to be exploring these preferences and priorities. So you might ask, can paternalism then be compassionate? And my answer is a resounding yes. What that requires is that the doctor knows the individual as best they can, and then it is their heart, it is their desire to make the best decision for that specific patient. But then you think, okay, how can we know? The consults are short. We can't do that. We can't communicate in the proper language. So how can we know? My first step is let's ask. So I've designed a cross-sectional survey really based off the incredible work that was done in Kenya and Namibia with the PRISMA study. It was a European design study that was modified and adapted to take to the streets there in Kenya and Namibia to understand better the preference and priorities of the people of Kenya and of Namibia. However, when I was looking through those questions, I thought we can do better. We can design measures. We can design questions specifically with African culture in mind. And that's what I've tried to do. Some of these questions on the survey that I've designed are asking, where does an illness like cancer come from? We want to understand what patients perceive, what they're thinking. What's the first step in treatment? Do you go to the traditional doctor or do you go to the hospital? What do you do first? Or maybe you do both. What's more important to them, traditional medicine or pharmaceuticals? Other things like who should be involved in medical decisions? Who should have the final say? Where do you prefer to die? Is it more important where you die or where you're buried? Because oftentimes here in Mozambique, somebody is being treated very far from where they live. And so if they're treated to the end of their illness, they may not be able to be buried in the land of their ancestors. So we need to know what is most important to Mozambicans. How's this going to help us? Well, the primary data analysis that I'm going to do with this survey is to focus on what patients want when treatment stops working. So we want to know, what do they want? Do they want doctors to be completely honest? Would they rather doctors send them home with hope that maybe they'll get better and come back? What do they want? This information will help us with medical decision making at the end of life. So what am I envisioning next? After this survey is run, the hope is that it will be run next month in March, and then I will do my data analysis and publish the information. From there, I'm hoping to translate the questionnaire into every dialect and perform this survey nationwide in each province so that we can know better, okay, patients from this province tend to have this spirituality and they prefer these things at the end of life. And these people from this province prefer something else. And that will help our doctors here in the capital city know, okay, I'm dealing with a patient from Tet. I'm dealing with a patient from Kelimani. And so I can know that patients typically want these things. And then I can make a compassionate, paternalistic decision that decides on the intervention necessary that will improve the quality of life for that specific patient. I also then want to look at our results, look at what we have, and identify topics that we can do further exploration through qualitative interviews. I will then try and disseminate all this information to healthcare providers who specifically work with patients at the end of life. That way that they can know their patient, know the person sitting in front of them a little bit better. And then my hope is maybe we can potentially replicate this survey in other African countries and make some comparisons and differences. So I'm very excited about everything going on. And I think it is extremely important. Again, palliative care is based on the preferences and priorities of our patients. We just need to understand how best can we elicit that from them? How can we know them better? And I would beg to offer that sometimes that medical consult, because of all those reasons I talked to you about the need for paternalism, maybe that consult isn't the best place. And I loved the idea that happened in Kenya and Namibia. They went to the streets and they started gathering this information, and now we can work with that. So I'm very excited. I hope you are too about everything that's going on in Mozambique. Thanks again for having me. Hello, I'm so
Amazing work from Mozambique. I think we're going to continue on. Is that right, Gary? Or are we moving on to the next session?
Yes, I think Eve should be there as well.
Great. Eve, I don't think needs too much by way of introduction, but Dr. Eve Namasango is the Programs and Research Manager at the African Palliative Care Association. She holds a PhD in palliative care and rehabilitation and has extensive experience in end-of-life care, health equity, and research on patient-centered models of care. Her work focuses on developing quality of life frameworks, caregiver support programs, and training strategies for healthcare professionals in Africa. And we are excited to hear from you, Eve.
Alyssa Tilly is there, of course, as well.
Apologies. Yes, of course, Alyssa, not meaning to overlook you. I apologize.
No worries. I think it was introduced yesterday as well. So.
But I don't think we're going to have time, to do what we had intended, because we're almost at the end. We only have a short period of time left. I think maybe we could just make a few comments, just communicating informally with Eve. I think our plan, the plan, I think these 2 days have just been outstanding. There's been such a richness of content, and we've heard so much about the problems in Africa, the challenges, solutions. We've heard a lot about culture and the cultural context and solutions that are relevant to Africa. I think the challenge, of building research infrastructure, particularly in this area, I think is great. We have some very powerful beginnings of interventions and of trials and research approaches. But I think we're thinking maybe to have a subsequent session, which might be at the APCA conference, but to have a subsequent session just on building research in Africa, how to build culturally relevant research and how to build research infrastructure in Africa in these areas. And of course, this is an issue not only in our area, but in people working in cancer and other diseases and building the research structure there as well. And, I don't know if Eve or Alyssa want to make any further comments, if they can say a few words just about And Alyssa, maybe you could say something in those comments just about your own experience building research in Malawi, what the challenges have been for you or the advantages have been for you as well.
Yeah, I think a conference, a symposium like this is incredibly helpful. As I alluded to in sharing with you all about our work on the quality of dying and death questionnaire, for me as an early career investigator, it was so helpful to be able to connect with Dr. Roden and others doing work in this area to kind of have form those partnerships, to have those examples, to be able to engage in mentorship. And that has been a huge benefit in working to further establish palliative care research. I have the great fortune of an incredible partnership and infrastructure through the University of North Carolina Project Malawi, but there wasn't a lot of focus on palliative care. It was mostly from an oncology perspective. And so being at meetings like Aortic in the past, meetings like this give us such a great example to see the wonderful work that many, many people are doing and to be able to reach out to one another and collaborate and work together to see how we can continue to further research efforts in Africa as a whole.
I don't know if Eve is still, she may be disconnected at this point. Is Eve still there?
I'm here, but Gary, I'm here.
Okay. Do you want to say a few, we don't have much time, but do you want to say a few words about next steps and about the conference?
Yes, it is to sincerely thank all the presenters and everybody who has joined us for this symposium. And we are setting the right agenda for the region to address the issues of end-of-life care, grief and bereavement, advanced care planning. And these are important components of palliative care, which we need to pay attention to. And I trust that we are going to continue the conversation at the APCA conference in Botswana come September from the 23rd to the 26th. Thank you so much, clinical care providers, donors, sponsors, and all our partners, patients and caregivers. Thank you too. Thank you.
Thank you. And maybe Eve, we can think of this as one small step in building a community of people who are interested in building palliative and end-of-life care, and particularly building research around culturally relevant and appropriate intervention. So we hope that all of you, this will facilitate the communication of each of you with each other. And of course, with us, we'd be very pleased to hear from you. And we'll keep you posted on next steps that we're going to take to do our part in building this community and building research in palliative and end-of-life care in Africa. Thank you all for coming. It's a lot of time to spend online, and it's been enriching for us. We appreciate that you've all taken the time to be here with us and with each of you. Thank you again to the just outstanding presenters that we've had.
Thank you, and bye, everybody.
Bye-bye, everybody.
Thank you. Bye.
Bye-bye.